Sandeep Goyal, our president, and Dr. Sandeep Grover, president, editor of IPS North Zone. And we are joined by many postgraduates, and we'll be starting on time to finish on time so that we stick to the time schedule as allotted by in the scientific program. So Dr. Arshad is with us. Thank you very much, chairpersons, to be there on time. And it is 9 o'clock, so it's over to moderator to start the session.
Hello and good morning to everyone. I welcome you to the first session on the second day of PGDP 2021. It is an honor to moderate this session. I'm highly thankful to the organizers for this. It is also an honor to moderate this session because the speaker is none other than Dr. Arshad, who has been my teacher during my post-graduation. And the topic he will be deliberated upon is his favorite topic right from his post-graduation. So definitely it will be interesting and informative. There's no doubt in that. So I welcome you, sir. So it is a proud privilege to introduce the chairpersons for the session. We have with us Dr. B.S. Shekhawat, who has done MD from SMS Medical College, Jaipur. He is currently working as a senior professor in the Department of Psychiatric, Government Medical College, Kota. He is a recipient of Solanki Gold Medal. He has served as a president and honorary general secretary IPS North Zone. And at both times, the North Zone was awarded Best Zone by IPS. He has organized many conferences, including PGDP 2011, midterm CME of Indian Association of Private Psychiatry 2011. He has many publications in national and international journals. He is the founder of the telephonic helpline Hope for coaching students. He is life fellow of IPS, IASP, IAGMH, AIPI, IAPP. He is EC member of IPS and EC coordinator of Ethics and Preventive Tribal Psychiatry Subcommittee of IPS. We have with us Dr. Naukiran S. Mahajan. She has done MD from DMC and Hospital Ludhiana. She is presently working as a professor there. She has numerous international paper presentations and many publications and chapters in books. She has been the president of Punjab and Chandigarh branch of IPS. Her area of interest is general adult psychiatry consultation, liaison psychiatry and clinical research. Welcome, ma'am.
Thank you.
We have with us Brahmdeep Sindhu. He has 20 years of experience in the field. He has done MD in PGIMS Rohtak. He is presently working as a chief medical officer in the Department of Health, Government of Haryana. He is the past president Indian Psychiatric Society North Zone. He is author of numerous publications in national and international journals. I welcome you, sir.
Good morning. Good morning.
For further proceedings, it's over to the chairpersons.
Good morning, all. I welcome you all with my co-chairpersons, Dr. Naukiran Mahajan and my dear friend, Brahmdeep Sindhu. It is indeed a great pleasure that although we are not able to meet personally, physically, but we can see the faces of each other. And this PG development program is, as you all know, is very important for postgraduates. This was basically designed to give technical skill, soft skill of psychiatry, which are not available in smaller colleges. So we have a galaxy of speakers and experts in the field of psychiatry. And it is basically benefited for PG students so far. And I think this will also be certainly a good experience for PG students. Without wasting time, today's speaker is Dr. Arshad Hussain. Although most of the people must be knowing about him, but it is a customary to introduce the speaker. So Dr. Arshad Hussain is a professor, Institute of Mental Health and Neurosciences, Kashmir, which is an associated hospital of Government Medical College, Srinagar. Dr. Arshad Hussain did his MBBS from the Government Medical College, Srinagar, and MD Psychiatry in Institute of Mental Health and Neurosciences, Kashmir. He is expert and interest in trauma, bipolar affective disorder, metabolic syndrome. The theme is related to metabolic syndrome, neurocognitive disorders. And he is the co-investigator in various ICMR funded projects. And he is also recognition with Japanese Society of Psychiatry and Neurology Fellowship, World Association of Social Psychiatry Fellowship, and guest editor of COVID Special Issues, Journal of Medical Sciences. He is also having affiliations and membership of various scientific bodies, including Convener, Disaster Subcommittee, Indian Association of Private Psychiatry, Convener, PG Psychiatry Education, Subcommittee of Indian Psychiatric Society, Chairperson Award Committee, member in Indian Psychiatric Society North Zone, and he is also a member of Indian Association of Social Psychiatry. So he is a very learned man, well connected. We have seen numerous times he is speaking well on this topic. And today he will also speak on treatment of depression in diabetes, necessities and consequences. Now I request my co-chairperson, Dr. Naukiran Mahajan, to introduce the topic, and my another co-chairperson, Dr. Brahmdeep Sindhu, will handle the question answer session. Thank you all. Thank you, the organizers, for giving me the opportunity. Now I request Dr. Naukiran Mahajan to introduce the topic. Thank you, madam.
Thank you, sir. Good morning to everybody, and a big thanks to the organizers of the event. So today's topic is very, very relevant to our clinical practice today, the treatment of depression along with diabetes. So we know that in our clinical practices, I think probably diabetes coexisting with mental illness is probably one of the commonest comorbidities that we encounter. I think everyone will vouch to that. And as budding students, budding psychiatrists, and people who are in clinical practices should be very well versed with the occurrence, the recognition of diabetes, how to go about investigating this illness, how to go about treating it. As you very rightly pointed out, sir, not everyone is going to have the facility to be sitting in a very well-equipped center when we are in our practices in the future. So we have to know how to deal with these patients. We have to know what to expect. We have to be well-versed with the drugs used. We have to know and be well-versed with and learn to recognize the complications. So I'm sure we are going to hear have a very good discussion on this topic. And at the end of it, I am very sure we are going to come away very enriched, and all the students are going to take away some very pertinent points which they will carry forward into their practices. So I think I will request the speaker to start his talk.
Very good morning, everybody. And it's a pleasure to be here. Thank you, Dr. Sandeep and Dr. Majid, for letting me to speak on this topic and inviting me for this postgraduate development program. It always has been a pleasure to be part of postgraduate development programs. My friends there, Ravi, Sandeep, vouch for the fact that, all of us, we are the generation who have actually grown with the postgraduate development program. I remember the second postgraduate development, the first one was a low-key affair, but the second postgraduate development program, which happened in Timber Trails, I was one of the postgraduate students who went there. for me, going from Srinagar to Chandigarh and participating in that program has left permanent imprints on me. That important was this program for me in life. That's why I hold it in very high esteem always. Seeing people like Professor Avasti, Professor Nimesh Desai talking there left an inedible mark on me. Meeting Professor Savita Malhotra there, a lifetime teacher, and many others. I might be forgetting many others, and listening to them, interacting with other postgraduates was such a wonderful experience that it actually left an inedible mark on me. In fact, I carried lots of friends from that postgraduate development program. The speaker after me, Dr. Ravi, and me, in fact, became such close friends after that program. We met there and became almost close friends there. And those experiences which I learned there, listened to, made me believe in this, that this is a very wonderful program and we should carry it. And thankfully, it's still carrying on. Regarding today's topic, we'll be talking about depression and diabetes. In the scope of this discussion, we'll be discussing about the relationship between the two. We'll be talking about the research and primarily our own research from the Institute of Mental Health and the consequences of this comorbidity and necessity to treat depression and diabetes. I remember 20 years back when I was a postgraduate, first year postgraduate, and I joined the Department of Psychiatry. Before that, I had done a 6 months housemanship, and I already had a research paper, published it on post-traumatic stress in a good journal, while I had worked as a sort of a field worker. But one of my mentors, Dr. Zafar, who had recently joined for NIMHANS, assigned me this topic to study relationship between depression and diabetes. And like all other postgraduates, very enthusiastic, at that time in Kashmir, this postgraduate entrance had happened after years. I think from 94, no postgraduate entrance had happened, and this was one. So all of us were very enthusiastic of getting a postgraduation. And we will be searching libraries, and we had a very decent library in GMC. All of us will be searching library for the topic, and I kept on searching, but I couldn't find any relevant research in the topic at that point of time, with all the journals which we had of psychiatry and even endocrinology. But what I found was lots of statements, particularly in the endocrinology journals, about diabetes made exactly in terms of a psychiatric illness, as if diabetes was a psychiatric illness. And that really set the interest in me. And this statement will be one of the earliest scientific statements about diabetes. Diabetes is the result of sadness and long sorrow. Now, while in the scope of my discussion, I'll tell you that probably what Wills meant. And this Maudsley statement actually holds true till this date. The diabetes is a disease which shows itself in the families in which insanity prevails, whether one disease predisposed one to other disease. Are there independent outcomes of common? They're certainly found to run side by side and alternate with each other. And this statement actually almost holds true till now. We still are actually discussing and debating diabetes and depression relationship within the paradigm of this Maudsley's relationship. Now yesterday you might have listened to metabolic syndrome and its occurrence in psychiatry, and you might have listened about the treatments which psychiatry patients receive and their predisposition to metabolics, and their occurrence together is something which is discussed hugely in psychiatry at this point of time. And to me, the basic question of why I'm studying diabetes and depression got answered as soon as I joined the Department of Endocrinology in SKIMS which was one of the first endocrinology departments probably in India, one of the first, definitely in India, where they had an independent endocrinology department. Very good department with lots of research base, and I joined that department. And my first impressions outside the outpatient department of that endocrinology department made me to understand why I'm studying depression and diabetes. A cursory look at the outpatient department would tell me that actually I'm seeing the same patients. These are the same patients which come to my outpatient in psychiatry, and many of them actually come to the endocrinology as well. So this started, there is something, a cursory look, as I was starting research, and I started getting interested in more. I'm actually talking about 2000. And our teachers here and the people who have started actually learning about psychiatry at that time will tell you that psychiatry was very fringe at that moment of time. And we were not mainstream in most of the departments. But luckily, I was a little bit mainstream because people knew me. I had been selected in that institute. I was probably fifth in that list, and I had not joined there, and I had gone to psychiatry. That background in most of the endocrinologists there, that he had a selection, made them to actually cooperate with me a little bit more and give me a little bit more sort of encouragement than they actually will give to the students of other branches. And that research, which we actually did during that time, part of it I actually presented in European psychiatry as a bursary, as a supported bursary, and undoubtedly, these two statements I started making as early as 2001, that major depressive disorder and diabetes are closely related to each other, and depression is inordinately high in people with diabetes and major depressive disorder. People, this statement was a big statement in endocrinology department at that point of time, that people who have depression are telling endocrinologists that people I screen and find to have depression are the people you're seeing very regularly and increasing diabetic medications, or increasing their insulin levels. In spite of that, they do not actually, somehow the things don't seem to be falling in line, and what's happening is that the diabetes don't seem to be getting in control. And this study we published long after that about depression and diabetes, saying the same thing almost, that depression is very common in people with diabetes. In type 1, it's a little bit much more, and then type 2, but there could be other confounding factors as well. And also that glycemic control, the point of glycemic control again being reinforced, that the glycemic control per se, the pivotal thing in diabetes, whatever we do in diabetes is to get the blood sugars in control, and depression and psychiatry seems to be very pivotal in that control. I'll keep on telling you about that in my future slides as well. And I demonstrated this fasting blood sugar of higher fasting blood sugar in people with diabetes in that study. And that was something, when you saw that statistically, when you saw that significantly, when you saw that in scientific manner. One was that cursory look at the outpatient, where I saw large number of patients sharing the outpatients, and another was actually now trying to demonstrate it biochemically, trying to demonstrate it scientifically, that depression and diabetes has a link, and that link seems to be much more than a cursory link. There seems to be, depression seems to be affect the diabetes as an illness as such. We have lots of Indian data coming since then, and most of the studies almost say the same thing. There doesn't seem to be anything different in most of the studies. There might be some studies, in fact, I know of, which don't agree with what we are saying, but most of the studies actually say the same things what we are saying now. And the relationship actually has been, while I did this of tracking diabetes in people with depression, but this point of relationship always was something which struck me, that while I was screening them for depression, the people who I actually saw, I did find this right from the beginning that many of them actually had started with depressive illness prior to actually being diagnosed as diabetes. That time there was not much literature on that as well. But remembering Maudsley's statement again and going back to Willis, you started actually believing in those statements of that, how commonly the diabetes and depression occurred, and that the diabetes occurs in sorrows. That statement came so many, of thousands of females, of diabetics females I talked to. I'm actually not trying to find an etiological link. I do not have data to support that. But I do not see, one, the people who actually had depression, I'm actually not talking about that. But every female who had diabetes, and I talked about, particularly, and I'm particularly speaking about females because there was a large population of females in this, diabetes sample at that point of time. And I found out that many of them will talk about sorrows. I'm not talking about depression. We'll talk about the sorrows, the daily sorrows, before actually they actually develop a diabetes. And they firmly believe, whether I believe it or not, whether science believe it or not, but those females firmly believed that these were the sorrows which will actually lead into depression, which will actually cause depression in them. Now we have lots of literature on this as well, that how depression actually predisposes people to diabetes, and vice versa we have been discussing. This hand and egg story has been, there have been proponents which will talk about that the diabetes came first. There are people who will say that depression came first. But me per se, and many others in this world who have done research on this, are firm believers that, as I have actually discussed in my previous presentation on MAC-PCOS as well, that we are probably this non-communicable disease and mental illnesses epidemics, if you actually track their trajectory right from the beginning, you will understand that their trajectories go so much hand in hand that we just cannot put them in different buckets. They seem to be rising so closely to each other that probably the links which are still being investigated, and we are continuously investigating them, how we might not have found them completely etiologically, but there seem to be links much more than could be actually discussed in in periphery, or without having the causality links or associations. There seem to be common factors which are actually giving rise to these illnesses together. And we have been discussing about how human evolved. There was times, probably many of us we will be in medical wards as MBBS students, and we'll hardly see a diabetic admitted. Diabetes was a sort of, while we will study about it, but it was a peripheral illness. We hardly see people admitted. Ours were the times of rheumatic heart disease, other illnesses. I'm not talking about, I'm talking about 2000s and 90s. And then the rise, one that here, and another, that the global rise was prior to that. They seem to be so closely associated, the anxiety, depressions, and the diabetes, that it does seem that there are certain common etiological factors which probably link them, rather than one preceding the other. And long-term impacts of this comorbidity, all of us know that people who have depression and diabetes, there will be less dietary self-care, there will be poor physical and mental functioning, there will be poor concordance with the medications in type 2 diabetes, there will be loss of economic, social roles, affecting marital and family life. There will be increased risk of diabetic complications. There will be poor cognition. Meta-analysis of about 16 longitudinal studies actually speaks about positive association between depression and subsequent mortality. There's 46% increased risk for all causes of mortality. Premature cardiovascular disease, the most common cause of morbidity, mortality in people with diabetics and comorbid depression. There's poor control of HbA1c, blood pressure, cholesterol. Compared to non-depressive patients with type 2 diabetes, those with depression are twice likely to have poor adherence to medications. Patients with high psychological distress, low social support, and low self-efficacy have symptoms associated with poorer diabetes and self-care. Effective depression treatment might ameliorate these negative effects. Despite recognition of conspicuous public health threat posed by comorbid depression and diabetes, only few studies address that issue. Much of the evidence that guides the management of depression in type 2 diabetes and other medical illnesses is drawn from randomized controlled trials performed in psychiatric samples. These are some of the studies which actually talk about that how important are the behavioral determinants in glycemic control in type 2 diabetes. And I again emphasize on this fact that whatever we actually are doing in diabetes, whatever medications we are using, whatever we are doing is just to have that glycemic control. And I think psychiatry has a very, very important role in having, in not only improving that goal of glycemic control, in setting up those goals, in continuing with those goals, and in lowering the complications actually caused by diabetes. And this is across board now known. In fact, all diabetic association guidelines, any guideline you go through, talks about screening of depressive symptoms and how important it is to actually improve the quality of life, how important it is to actually improve on the glycemic control, and how important it is to improve on the complications if we actually early recognize the depression in people with diabetes. And now we reach to the recognition and diagnosis and the treatment of diabetics in depression in diabetics. Now, one is that people who have frank depressions in diabetes. And second is that prior to that, also the mental health has a huge role. People who now work with psychoneuroendocrinology are invest. As you know, that collaborative care is very, very important. And even anybody who's diagnosed with diabetes, they try to do lots of measures which they think that will be preventing in having the mental health burden later on in the diabetics. And among them, educating people about the diabetes, what it is, what are the treatment options, the nutritional management, talking about the physical activity. Now, ultimately, making people to believe in the physical activity, using medications safely, monitoring blood glucose and other parameters, developing personal strategies to address psychosocial issues and concerns, developing personal strategies to promote, healthy behaviors. All of these factors actually go a long way in helping people with diabetes to, forego those day-to-day stresses when people get diagnosed with diabetes. So it's a very big thing. It's something which they'll be having lifelong with them, which they will have to fight day in and day out. From their habits, everything has to change after that. And you could actually make that change look very, very positive in people with diabetes. Give them very hopeful scenarios even after they are actually diagnosed diabetes. By that, the psychological burden at least will be carried. Even though I'm a firm believer that there's much more than just the psychological burden of diabetes, which actually leads to depression in them. But yes, the parts played by that could definitely be modulated by once we start talking to them early. Otherwise, if you have been in an endocrinology clinic, it's usually a one-way thing. The patient comes, he sits, he shows his blood sugar fasting, and depending on that, you increase or decrease medication, and you see the other investigations, and based on that, you base your treatment. There's very little interaction happen, and my endocrinology friends and skills will tell you that how the whole system changed when I actually joined that place. Stayed there for 3 years, and how that talking actually changed almost everything for diabetic, and just simple talking, making people humorous. I remember when I started assessing, it's very pertinent when I started assessing people for diabetes, and I started, obviously I had questionnaires, and I had to start asking questions, and I started asking, I had Madras along with me. We had not started doing Hamdi. We worked with Madras, and I'll start asking this first question about sadness, and I started getting a reply of almost everybody is sad, and then I started asking about food habits, like how is your appetite, and this answer will make everybody laugh, and these females will tell that in Kashmiri they will say that, what appetite? Everything which is sweet in life has been stopped by endocrinologists. How could I enjoy my life? Those kinds of statements. And actually, when I started talking to them, and when I started actually, I started working on the nutrition, and I started thinking about lots of foods which still could be given at that point of time. I do understand now, even endocrinology has gone lots of changes, and diabetic associations do talk about the education now, and do talk about talking to patients. They also do it now. Many of the endocrinologists, they talk to these diabetics, they tell them about foods they could still take, they tell them about some cheating which could they do day in and day out, and they also they don't make diabetes look a huge psychological burden, but but still it does get lots of restrictions in human beings about what they want to do and what they do not want to do, and that really is burdening. Most of the associations now do talk about assessments, and they do talk about various, use of various guidelines in doing that assessment. I myself will used to use Madras, but while I know that most of the guidelines, most of the current research does talk about various scales to be used, but I still don't find a replacement to the good clinical history and interview taking. I think that's very paramount, because yes, no answers in people with diabetes many a times might make you to overdiagnose things, hugely overdiagnose things. And while I was doing this, I learned it very early that it's very important to form a therapeutic alliance first. It's very important to actually get into them first before you actually started the clinical interviews, which are based on scales. It's very, very important, because otherwise many times it gets very mechanical with them. You start that sadness which they speak about. You only start feeling it when you do a clinical interview or a history taking, good history taking. Otherwise, by that, only doing assessments by means of questionnaires might make it hugely overdiagnosed, because there's so many commonalities between depression and diabetes otherwise. In fact, the assessment, the psychiatric assessment should include other things as well. And among them, I always thought that males will talk a lot about the sexual side effects, which they had not talked to endocrinologists ever, and which was hugely burdening on them. while they were diabetics. And when we started taking history, I was able to actually find out, and many times that link of having sexual dysfunction was so vital, because these patients actually will come day in and day out to endocrinology OPD. They will be called to come after 6 months, but they will come after 1 week, unable to talk about their sexual dysfunction. That's something which is very vital actually to talk about. These are some of the validated questionnaires which have been used, even though I have not used them. I actually have used MADRS, but these are some of the validated questions which the studies world over have used. Management of depression in diabetes is like any other, you could actually put it into the paradigms of other chronic illnesses. You detect depression very, very early. You use both medications and therapies in them. By that, you not only treat depression, you empower them, you improve their cognitive skills, their self-esteem, all other things are improved, which in turn actually affect the essence of diabetes, how to control diabetes, not only by the medications, by improving their physical activity. It also improves their ability to talk to their physicians. It improves their socio-occupational functioning, and it in turn improving their quality of life, which in turn actually helps in controlling diabetes and improving depression as well. This is true about many other chronic illnesses, and this is true about diabetes and depression relationship as well. Even though most of the depressions I saw over periods of times are usually moderated severe, and pharmacotherapies did form a very important role in my in my research as well, and beyond that in sort of a psychoneuroendocrinology clinics as well. But there's a lot of research about using of therapies, particularly cognitive behavioral therapy, in people with diabetes, and improving depression as well as glycemic control. We have not done a study on that, but I do think that there were lots of people with diabetes. If I don't say, in those settings, I was in endocrinology settings, it was very difficult for me to do cognitive behavioral therapy. But I did almost in every patient do cognitive behavioral talking. What I say, cognitive behavioral talking was very important, essential part of my overall talking to patients, because for me it was not just about screening, diagnosing. After that, aftercare was all left to me. Once they sent the patients, aftercare was actually left to me as a postgraduate. So I did develop that sort of cognitive behavioral talking with patients with diabetes. I found it very, very effective. One, that helping developing a therapeutic alliance, and second, that in improving the quality of life and improving the glycemic control. If my cognitive behavioral talking did nothing but only improve the adherence in people, it was a huge job done. I do think that there were patients wherein the huge difference happened by just talking to them and making them to adhere to the treatment, and using cognitive behavioral styles to actually do that. And endocrinologists found that sort of great things done without actually doing anything. They thought that just by talking, if somebody is you could make people to adhere medications are wonderful. And psychiatrists have a huge role in that actually. Because we over a period of time learn to do that. Our style of talking is many a times now it is cognitive behavioral, and actually by improving that, you could improve the glycemic control, and you could improve ultimately the diabetes care per se. So there are various support, and now that in fact in almost all endocrinology departments world over, there are therapists, in fact nutritionists. All of them actually do not the same thing. They educate people, they use cognitive behavioral styles to improve their day-to-day living in a way. Ultimately, what does if you look at diabetes as a disease, what does diabetes demand? As happens with most of the diseases, even currently COVID, what does it demand? A behavior, a pattern of a behavior which is very regimental, which is very strict, You could have off days and or cheating days, but then a very strict regimental days. And what best then, behavioral modulations which could actually bring in that change. And if you know about them, if you are able to do that, you bring in great changes. While endocrinologists keep on prescribing medications, while endocrinologists take the horse to the river, but they can't make them drink the water. But you as a psychiatrist could actually do that and improve the glycemic control. So that is probably a sense of all the therapies which are used in the diabetics with depression. This is very essential part, and we'll spend few minutes actually talking about them. Most of us know, when I started work, when I actually took the topic, actually fluoxetine was the probably only medication available in the SSRI, probably available in the market at that point of time. But within some time, sertraline actually got introduced as well. To me, when I looked at I was looking at these two, currently you have guidelines available. I'm actually telling you that it was the times when my library did not have papers. And all the initial references which I got is thanks to some of the friends which got it from National Medical Library and from Bangalore, which actually, there was not huge talk about the treatment, which were actually talking about the associations and the link at that point of time. So the treatments, I was the boss. I had to decide about, what treatments. So I thought about, what kind of treatments. And I thought that, gosh, we had Stelopram. I thought that Stelopram will be an ideal medication. And do you know why I didn't think about that? I thought that at that point of time, because, I will not have to think of any interactions. Because any diabetic I will meet will be on 6-7 medications already. And I will really think about that. It was very new. I had come to a department. Even if I did not improve anybody, I did not want to get anybody sick, ill. And I did not want to, as all of us work with this no harm intention of doctors. So I didn't want to harm. So otherwise I had to, I did not have the sort of provision of having Google as the friends now have, our all postgraduates, because, I take class of my postgraduates on the days when the internet is blocked in Kashmir, because otherwise it's very difficult to take their class. They have Google at their Google Baba is on the mobile, so they could actually search anything. So that time we did not have Google Baba, so we had to actually think, and I think that was wonderful to think. So I thought of Stelopram as choice, but Stelopram was not available. And then the closest I was thinking was sertraline. So I started using sertraline. So I have used sertraline. I can't tell you how many. I used lots of sertraline, and the results were very, very satisfactory. Very satisfactory results in terms of that depression did improve, and the glycemic control which improved. I'm not saying in everybody, but in a good proportion of patients where glycemic control improved after we started treating them. And how much of that happened? Because once the depression went away, they started exercising better, they started taking their drugs better. I can't quantify that, but the results overboard were that glycemic control did improve after using the medications. Most of the research we currently have talks about fluoxetine, and they too talk about fluoxetine, one that, like any SSRI, like any other SSRI, it improves depression, so it will improve the other parameters in diabetes, or it will improve the depression in diabetes. But they also talk about fluoxetine's ability to actually cause weight loss, which might be contributing to its effect. But that time I had the fluoxetine option, but I did not use it much because of the interaction part of it. But now, as interactions are more clear, I have used fluoxetine also overboard, lots of it, while taking care of the interactions. And there don't seem to be difference in SSRIs, but we have to be guarded in the sense that, for example, paroxetine's weight gain might outweigh the benefits which you actually give by treating depression. That has to be kept in mind. But overall, for example, I have seen patients, I'm talking something from my experience as well besides research, because, I thought that I have been assigned this topic not because otherwise anybody could have done Google and found out lots of research on diabetes, is because I had some experience in that. While I found that people who had diabetes and depression and could not be prescribed SSRI because of some reasons. For example, I remember many of these patients now. I have a huge group of patients who had hyponatremia, which is a very common accompaniment now in this group. These are diabetics, and you will invariably find them hypertensive as well. You will find them with ischemic heart disease, hypothyroidism. So they are people with multiple non-communicable, this spot which comes together of non-communicable diseases. And they are on medications for almost everything. And by your psychopharmacology knowledge that these are the ones which are predisposed to hyponatremia as well. I did find lots of them, had hyponatremia. And the choices I had to make were, for example, mirtazapine choice. In good proportion of them, when I used mirtazapine, their appetite improved, their weight increased a bit. The depression went into remission, and it did not bother their glycemic control. So, what I want to say is that treating depression in diabetics probably goes much beyond just controlling their weight. So, weight should not be the only measure. I liked Sandeep's statement, Sandeep Bro's statement yesterday when he talked about in metabolic syndrome about treating schizophrenia with medications. When you have to treat schizophrenia, I watched for his statement that I know of people who had diabetic, hypertensive, ischemic heart disease, had refractory schizophrenia. When we introduced clozapine in them and they started getting stabilized, all other illnesses started getting stabilized, completely stabilized. And I could at least 6-7 patients on clozapine who have this kind of trajectory. So, this erroneous rationale of just that weight is very essential for controlling diabetes, depression diabetes, has some weight, but is not all. Probably the treatment goes much beyond that, and depression and diabetic actually affect beyond that relationship. So these studies of SSRIs are now, if you could see that these sum up almost all of the studies, fluoxetine, sertraline, escitalopram are somehow given more weightage than others. Fluoxetine has more research in its favor. That I have used more of sertraline, and there are reasons for me to do that. TCAs have been used, obviously when there were no SSRIs, and TCAs might have been used. Among them, if you see that nortriptyline has lots of research in its favor, and they have not only been used for depression control, they also have been used for neuropathies in them, but obviously with smaller doses. But I do think that the research overwhelmingly there speaks about their, the weight gain and other toxic effects of TCAs when we use them at the high doses, outweigh the benefits in many of the diabetics. Because we do not have to only take care of the depression, we also have to think of that these are the people who are predisposed to cardiac illnesses. These are the people who are predisposed to, the other illness as well. So there might be this factor which actually that's why the TCAs might be overweighing, TCA benefit might be overweighing the benefit of actually treating depression in them. But still, wherever you use it,
Dr. Arshad, your topic is very interesting and you are speaking well, but we have restriction of time. So
I'll make it in time.
So that we can have some time for question answer session.
Yeah, surely. I'll do that, sir. So, the SNRIs, the benefit of SNRIs, even though you see that duloxetine and venlafaxine are used a lot in peripheral neuropathy, they have not, I don't think they have an FDA approval for depression in diabetics, but generally duloxetine, they have not found that, it offsets the glycemic mechanisms, and wherever you can use them, can be used, I think, with good, for example, it's better to use a single, and I do that very often, that if duloxetine has been already introduced, For peripheral neuropathy by an endocrinologist, I do not add an SSRI. I just optimize the dose of duloxetine. So that is how we could do it. I do the same with nortriptyline as well. And remember that many times look at the sibutramine as treatment in that, which is commonly used for the obesity or weight control in diabetics, and is an SNRI basically, and does have benefits in depression as well. Mirtazapine I talked about. MOVs have not been tried much because of this risks of hypoglycemia, and obviously because of risks of interactions as well. So all patients with diagnosis of depression should be screened for diabetes mellitus, and this statement is now well established. When we started this 20-year journey, there was no statement like this, but now it's a well-established statement that we have to, screen people with diabetes for depression. And in fact, the reverse goes true as well. You should continuously monitor your patients of depression for the diabetes and diabetes complications. SSRIs form the first line of treatments. We do not use much of TCAs and MOLs in them. We should continue monitoring their blood glucose, HbA1c as per the guidelines, whatever are in vogue. There are lots of trials. You could actually Google them and find out about various SSRIs, antidepressants, and their effects in depression, in diabetes. They're available, very well available. You could actually see them. And they further the same point as I told you, that it's very essential to treat depression in people with diabetics. And that way you do not improve depression, you actually improve diabetes as well. This is summary of how depression care actually improves care in patients with diabetes. And this bidirectional relationship between the two is can be very well taken care of by what I said, by screening people with depression in diabetics, and then actually treating with proper medications, and then following it up continuously so that the treatments are optimized and the benefits are optimized as well. So to conclude, there's a bidirectional relationship between depression and diabetes, and their shared biological behavior that predispose to underlie results in morbidity and mortality function burden. And joint efforts from endocrinologists, mental health professionals are very, very important. Though this collaborative care is true about now everything. We can't actually treat things in isolation now. We have to be in touch. We as psychiatrists have to come out of that cocoon, and we have to be in touch with the other professionals to actually one that give benefit of the science of psychiatry to the other professionals, and take benefit of the other sciences in the psychiatry. That's so vital for our new postgraduates. I tell you that if there are 3 areas which the new postgraduates should learn is metabolics, psychoradiology, and psychogenetics. Without that, the future psychiatrists will be incomplete. If we do not have, these 3 areas will be the essence of psychiatry. We really have to learn them by heart to be good psychiatrists of the future. Ours were very leisure times to be psychiatrists. Your times are going to be a little bit tougher. So please do concentrate, while you do study about the theoretical basis of psychiatry, of psychodynamics and all others, but the mind is going into the brain, and the more it's going into the brain, learn about the brain. And ultimately, we are the doctors of brain. Thank you so much for listening to me patiently.
Thank you, Dr. Arshad, for such a nice talk. And you could very well establish the relationship between diabetes and depression, both the illnesses being so common, and physicians bread and butter being diabetes, and psychiatrists having most of the patients having depression. So let us start with I would congratulate Dr. Arshad for such a nice presentation. And let's start with the question part. From the chat box, I would pick. There is one question which is visible is from Deepa. The college they have not mentioned. And the question is, what if a patient has shown improvement only on an antidepressant likely to cause diabetes mellitus? If it is someone which she means to say that there is a patient who is having antidepressant induced diabetes. So how much we approach the particular, how should we approach it, and how often do we need to routine sugar monitoring in such a case? That is Deepa's question.
Very good question. In fact, I did mention to that in the remarks in my presentation as well, that, one, that there is a lot of talk about in endocrinology research, in endocrinology books about the antidepressants, and that to now SSRIs, long-term weight gains and probably predisposing to diabetes. But I think there are contrary views in most of the psychiatry research about that. While we have well-established links of SDAs, certainly dopaminergic antagonists like olanzapine, clonazepine, the links are not so well-established still in the depression treatment. But yes, I do understand what Deepa wants to say. For example, if there is a patient who had depression and got well with mirtazapine only, let's think, or TCAs only, should we continue? This is my personal view, is that you will have to look at the patient per se. For example, severe depressions on TCAs. I have many people who had severe depressions, severe recurrent depressions on TCAs, were referred to me when they had developed diabetes, and I was asked to remodel their treatment. I did not. Because I think that the costs of depression in diabetics and costs of depression per se on the quality of life are much higher than this. What you could do is that you could optimize the diabetes treatment and you could optimize the other behavioral changes. For example, most of the links of antidepressants on the diabetes still are thought to be, for example, TCAs links are still thought to be for weight gain. If you work on the weight gain, if you work on the, while you are actually treating the depression, you work on the weight gain part of it as well, you might actually offset that link. So it's better to actually do that way. For me as a clinician, I will do that way, that if this is severe depression who was well on TCAs and is referred, I'll not change the treatment, but I will do the behavioral modifications and actually try to bring in the change in that factor which they think that are leading to depression by the change. But if the change becomes inevitable, for example, I do see that many a times I have certain patients where the change became inevitable. For example,
Dr. Arshad, can you brief the answer so that more questions can be taken?
Okay.
Because this is basically, if you give answer of such a long answer for only one or two students can ask. We want more and more students can ask. The questions answer should be precise.
One, that you could actually rationalize it from the from patient to patient, and second, that and looking at the risks as well. For example, cardiovascular risks are high with TCA, then that time you could consider. But if it's only diabetes, then you could actually, and the depression is more severe, and that's why he has been on TCAs, it's probably better to continue the treatment.
And nice, Dr. Arshad. And the next question is from Dr. Ashish Bhandari. He has asked about the correlation of depression in diabetics, and I want to ask whether it is wise to start early non-pharmacological treatment in advance once the patient is diagnosed with diabetes, even without having any depression.
Shikhawat, if you want me to give this one answer to such question, it's very difficult. So,
dear Arshad, our aim is, you are speaking very well, but our aim is to improve more and more.
Time is.
Everybody has chance to ask the questions. Otherwise, very limited question can be taken.
Yes,
that is my concern.
So, this is something, we can't do. Ethically, we can't do it still. Ethically, we can't do it till we establish that depression is one of the risk factors to the degree that moderating it early will actually result in, the improvements. We probably can't do it ethically now. But I tell you that there are patients, there are case reports to that, and there are patients which have had refractory course of diabetes, and we screened them for depression. We did not find depression. And the people who start SSRIs in them, there's some reports where they saw that the glycemic control started improving after using SSRIs. And in fact, this is almost in practice here with the endocrinologists with whom I work, that when they see a refractory diabetes, they do refer once for the assessments. I had 2 OCDs, obsessive compulsive disorder, which had varied, and I had 1 malingering among this all group which were glycemic. But to start it without having an indication has ethical issues. I would have loved to do that, but because of the ethical issues, it will not be probably possible at this point of time.
Nice, Dr. Arshad. If I'm asked this, I would say so that even if there is no depression, but there is no harm in starting the lifestyle modification.
Yeah.
In the beginning only. So a good physician is one who knows a bit of psychiatry.
True. Not one. All good physicians are good psychiatrists. Now, every good physician you will find. We have a name here in Kashmir called Alijan. If you look to his folklore, he has been just a psychiatrist. So every good physician is a good psychiatrist.
He's a good psychiatrist, right? Nice to say. Dr. Azaz is asking about how to address the issue of caretaker burden. And I would just improve the question and how to address the pill burden. Because the pill burden is there in depression as well as in diabetes, both. Both of the cases are having so much of that.
I think,
Dr. Brahmdeep, this would be the last question.
Okay, fine.
With permission of chairpersons, although it's not my domain, but at least my domain is to stick to time.
No, fine. The time 10 a.m. is visible.
The caregiver burden in both, we know that caregiver burden in diabetes is really huge. And pill burden is also huge. I fully understand that. Even though I have not worked with the families of people with type 2 diabetes, but I tell you that type 1 diabetes, care burden is very huge. Dr. Ejaz might be from the SKIMS issue. You might be remembering that we do almost an yearly program with the families who have this type 1 diabetic in the family. And, we do talk to them and lots of things. And care burden, I have found depression in parents of type 1 diabetics many times. Their sufferings are very huge because the treatments have not improved over a long time. About pill burden, it's very huge. It's very pity that this non-communicable disease, which have the simple answer of having, we as humans were made to be physically active. These legs are standing because we were asked to walk. We stop at that basic essence. And we are paying price by taking those multiple pills. And the burden of taking, the adherence is such an issue in all non-communicable diseases because the number of pills people have to take. If you should remember that if we have to take, as middle-aged people, we have to take 1 pill per day. It is such a huge difficulty to. But again, I think psychoeducation and behavioral modifications go a long way in helping that. How to take, when to take. Talking about that, psychoeducating is something which will help in decreasing the pill burden. Thank you so much. I will love to talk on this topic. I understand that there are time limitations always. Thank you so much for allowing me to talk for so long. It's always a pleasure to be here.
Very nicely summarized, Dr. Arshad, and we are thankful to the organizers. And here very well said that early diagnosis, collaboration between the physicians and the psychiatrists, and adherence are the keyword. Thanks to all the people who are at the present are having audience and who have submitted their questions. Because of lack of time, we could not take all of them. They were quite interesting. And maybe in a future due course of time, we can, Dr. Arshad will be available to address this question. Thanks to the organizer. Thanks to Dr. Arshad. Thank you all. Thanks to my co-chairpersons.
Chairpersons, our learned chairpersons, last thoughts briefly. Madam and Kautsar, any last thoughts?
I would just like to add here that SNRIs are a very useful treatment option because they treat some of the complications as well. In fact, in my practice, I see a lot of people who are already on SNRIs, which have been started by an endocrinologist. So that's a good treatment option available for these patients.
I also using SSRI in patient who is not having significant depression, but they have uncontrolled diabetes. So sometimes the endocrinologists think that they should know, they should be referred to a psychiatrist because they are thinking that some stress is there. So that's why they are not able to control the diabetes by giving anti-diabetic drugs. So change in the lifestyle modification or change in the lifestyle, and even starting SSRI without having significant depression is also helpful sometime to reduce their blood sugar level. This is my experience.
Dr. Brahmdeep, can we have the award-winning question? If out of 3 you can choose one.
Out of these 3 only, I have to mention.
Yeah, obviously, because 3 have only been
Because
asked.
we could not. My request is to every speaker, not only us, because we should give students more chance to ask questions, so that they have a lot of query in their mind, and they can. This platform can be used to satisfy their queries.
The first one, Deepa's question.
Very nice.
Is the best.
Thank you very much, Chairpersons, Dr. Shekhawat sir, Dr. Naukiran Mahajan ma'am, Dr. Brahmdeep, and my dear friend, Dr. Arshad. It's always great to listen to you. Your first love was diabetes and depression when you joined psychiatry, and it continues still, and you have been doing a lot of work in this area. Thank you very much for making us wiser as far as comorbidity in depression is concerned. Thank you all, and we have the best question winner, that is Dr. Deepa. She is from IMHANS, Department of Psychiatry, GMC Srinagar. And we have moderator as well, who will be felicitated by Dr. N.N. Raju sir, our Vice President and President-elect. Then we go over to the best question of the morning session. That is Dr. Deepa. Sir, kindly present it. Thank you very much. We move on to the next session. That is by our chief speaker, Dr. Ravi Gupta, a dear friend from AIIMS Rishikesh, and we have chairpersons in the panel. We are joined by Dr. Arabindo from all the way from Kolkata, and he's always traveling. I can see him always in the car. And next is Dr. Manish Patla, my dear friend from Mulana. And then Dr. Zadwani. I won't say he's my friend, he's my brother. We have grown up together since medical college days. Long back in 92, we are there for last 29 years, and pray to Almighty that we still continue to be together for a long time. Dr. Satish Verma as well, although he had some issues, but somehow last minute he could spare some time. So instead of 3, we have 4 chairpersons. Thank you very much all, and it is over to Dr. Jitendra Aneja, who is from AIIMS Jodhpur, to start the proceedings. Jitendra, are you there?
Yes, sir. Yes, sir.
Please go ahead.
Good morning. Good morning. I thank the organizers, but with just a correction that I have now shifted to AIIMS Bathinda as associate professor there. Good morning to every member of Indian Psychiatric Society and dignitaries of IPS North Zone and my teachers over DICE as well as offline. The topic is very relevant, and I welcome the chairpersons. Firstly, Dr. Arbinda Brahma, who is Director, Girindra Shekhar Clinic, Kolkata, Consultant Psychiatrist at Bharat Shevashram Sangh Hospital, Kolkata, and Lecturer of Indian Psychoanalytic Society. He is presently affiliated with as Honorary Secretary of IPS East Zone, Member of Rehabilitation Council of India, Chairman of Publication Subcommittee of IPS. He is convener of National Action Committee of IAPP as well as Zonal Member of National Advisory Board of IAPP. He has vast experience in research, also has more than 50 international and national publications, 3 book chapters, more than 100 lectures delivered in academic seminars and CMEs. And he has received many awards, which include 7 national and zonal awards of IPS and IAPP, including the prestigious Bhagavat Award in 2007 and Marfati Award in 2014. He's also been awarded with Mother Teresa Sadbhavna Award for social work. Next, I welcome Dr. and Professor Manish Batla from the Department of Psychiatry at MM University, Ambala. I had worked with him and he's a very good colleague of mine, I can say friend also. And he graduated from Varda in 2003 and further pursued his post-graduation from prestigious Father Muller's Medical College at Mangalore in 2006 and later on did his diploma in hospital and health management in 2009. He has a teaching experience of more than 15 years. He is in charge of de-addiction center at the college and is a recognized postgraduate teacher. He has more than 50 national and international publications and has contributed book chapters also. His area of interest are de-addiction psychiatry, child psychiatry, and sleep medicine. And the topic is also related to sleep medicine. So we hope a very productive discussion on this thing. He is a life fellow member of IPS, IAPP, and Indian Medical Association, and he is founding member and general secretary of IAPP Haryana branch. Next, I welcome Dr. S.K. Verma from the same place where I work. He is currently practicing as senior consultant psychiatrist in private practice, and he is there for around more than 30 years. He did his PG from DMCH Ludhiana. His area of interest are bipolar affective disorder and de-addiction psychiatry. He has organized PGDP also. He has organized IPS Nord Zone, which are held in Bathinda in 2018. He has successfully organized CME by IEPP at Bathinda also. He is currently honorary treasurer of IPS Nord Zone. He is former General Secretary of Punjab and Chandigarh branch of IPS and former General Secretary of Punjab and Chandigarh branch of IAPP. And his other area of interest are to make public aware of mental health issues and had delivered lectures in this area. The fourth chairperson is Dr. Jayed Ahmed Wani. He is professor and head of unit at Department of Psychiatry, GMC Srinagar. He has also contributed to research in form of various national and international publications. He was one of the first residents to start working in trauma stress research in Kashmir, and he continues to work in this arena till date. He heads the Child Guidance and Wellbeing Center at SMSHS Hospital. Over to the chairpersons.
Yes. Am I audible?
Yes, sir. Please go ahead.
Yes, sir. Continue. So, first of all, I will introduce the topic to the audience. The name of topic is Relationship of Metabolic Syndrome and Sleep. Sleep is intricately related to various metabolic processes in the body. Sleep deprivation, sleep disordered breathing, and circadian misalignment are believed to cause metabolic syndrome through myriad pathways. Understanding this relation is important as both metabolic syndrome and sleep are common and growing problems. Regarding this, there are many unresolved issues, including cause and effect, pathogenesis, and partial implications to therapy. Now, we will listen to a very learned speaker and authority on sleep disorders, Dr. Ravi Gupta. I will request the next person to introduce our speaker.
Good morning, everyone. It's my honor and privilege to introduce the speaker for today. Do we have two speakers or one? Because
we have one speaker, Dr. Ravi Gupta.
We have two speakers today in name of Dr. Ravi Gupta. We have a psychiatrist by name Dr. Ravi Gupta and a stalwart in the sleep medicine, because I have been silently following him since last few years. No doubt the topic, although from our forum of psychiatrists, it's an honor to introduce him. He is an additional professor working in the AIMS Rishikesh and has a teaching experience of over 20 years. He has been awarded with the prestigious Indian Psychiatric Society Young Psychiatrist Award, Fellowship from World Psychiatric Association and Japanese Society of Psychiatry and Neurology. In addition to his 152 peer-reviewed publications, he has authored a book named Clinical Atlas of Polysomnography. Many of us might not know this, but sir has very beautifully written this, authored a book of work excellence in the field of sleep medicine. He holds prestigious positions such as the Guideline Committee member, World Sleep Association, member, College of Expert Review, European Society Foundation, and is currently the chairperson of UG Education Subcommittee, Indian Psychiatric Society. He is one of the very few psychiatrists who has been made a name, fame, and is considered as a stalwart in the branch of sleep medicine. Over to you, sir.
Dr. Arbindo, you can speak for a minute, then Dr. Zayed would moderate the question answer session. Dr. Arbindo, are you there?
Okay,
Yeah.
okay. So, thank you very much. First of all, I must thank Dr. Shandip Goel, Dr. Abdul Majid, my dear brother, and the IPS North Zone for inviting me. It's a great honor to me. And regarding Dr. Gupta, nothing to say more. Just 2 weeks back, we heard his lecture in the Delhi in IPS midterm CME, and we know it is always pleasure to listen something from Dr. Gupta. I can say that now there is evidence of sleep and alteration in the sleep architecture, like obstructive sleep apnea. They are the major risk factors for obesity and cardiometabolic risk in both in adult and children. Especially children are now matter of concern to us. And very recently, body of data has begun to emerge that there is a link between chronotype and circadian rhythm disorder and obesity and the metabolic syndrome. So I think it's a very important topic, and all the PG students and the clinicians, everyone will be benefited listening from Dr. Gupta, because we know on this particular topic, there is no time to sleep on this particular issue. And we know Dr. Ravi Gupta is always awake and making us awake as well, so that we can learn a lot from him. So thank you once again. And may I request Dr. Ravi Gupta if he can start his talk right now. Thank you.
Thank you very much, sir. Manish, Arvindo Brahma, sir. And then who is there? Zayed, Dr. Zayed, and all the dignitaries present in the hall, Raju sir, Vinay sir, Chadha sir. It's indeed a pleasure to be here, and I would be really thankful to the North Zone, Mazed, Sandeep and Sandeep for inviting me here. Because I basically belong to the North Zone. Of course, I've shifted to the Central Zone. That's a different issue. So maybe in the next 40 minutes, we'll try to examine the relationship between the sleep and the metabolic syndrome. Before that, I'd like to disclose my conflict of interest. So there is no conflict of interest related to this presentation. So this talk I have organized in certain sections. So first we'll try to discuss about the definitions of metabolic syndrome. Of course, Sandeep has covered it. So because I'll be talking about sleep so many times that you can actually fall asleep. So just to make you awake, I will expect that you will come with some kind of say responses, and we'll try to keep this discussion interactive one. Then we will try to examine the definition of sleep, and then we'll look at the scientific data. That's a bit boring part, because say we'll be talking about the odds ratios and the other things. And then the interesting part is the pathophysiology, and then I'll summarize my talk. So can anybody tell me which definition is this? Which of the organization gave this definition of metabolic syndrome? I think you can recall the lectures from Sandeep. Please be loud. ATP. NCEP. No, this is not NCEP definition. No, this is not modified NCEP. This is IDF. Okay, this is IDF definition for the metabolic syndrome. So it's actually really important to understand the different definitions and say what are their impact and how do they differ and how the commonalities between them. Because say the different papers that I'll be quoting, they have used different definitions, and that can actually affect the or influence the outcome of the paper. So, any other definitions for the metabolic syndrome besides IDF and NCEP? ATP, okay. WHO, okay. And HALE, okay. And AHA finally, okay. So when we talk about sleep, sleep is basically a state of consciousness, and we can say it's altered consciousness from which arousal is possible. So it's a reversible thing. When we compare to the coma, from which the arousal is not possible. And during the sleep, actually there is a disengagement to and from the environment. So whenever we are sleeping, we are not able to say feel anything from outside the environment and from within the bodily environment. And say we are at the same time, then when we are not able to feel anything, at the same time, we are not able to respond as well. So during the sleep, most of the bodily functions, they function on the basis of the ANS. We all know that. And when we look on grossly, then it's states of behavioral quiescence. So if a person who's sleeping and who is not behaviorally quiescent, that means there is something wrong with the sleep. Okay? Next, please. So let's try to examine the scientific evidence. Okay, can you tell me how much do you sleep on an average? 8 hours. 8 hours. Anybody who's sleeping less than 8 hours a day on an average? 6 to 8 hours. Anybody sleeping less than 6 hours a day? Please raise your hand. Okay. So this is important for you. The next few slides. Anybody sleeping more than 8 hours a day? How many of them we have? On an average. Okay. So I think you will be benefiting. And do you think you are sleep deprived? How many of you think that you are sleep deprived? He has acute sleep deprivation, of course. Okay, 2. So when we talk about the sleep deprivation can be acute or chronic and partial. So acute means, for example, Majid was not able to sleep last night. So that can be total sleep deprivation when you are not able to sleep the whole night. So you are awake for more than 24 hours. And much more important and much more prevalent is the partial chronic sleep deprivation. So we see these days the youngsters who are working, or maybe say working on the laptop, or say playing with the mobile, or watching some kind of TV shows, and they are getting themselves sleep deprived. So they may require 6 hours or 7 hours or 8 hours of sleep, but they are depriving themselves for say half an hour or 1 hour every day. And the trouble is this partial sleep deprivation has a cumulative effect. So after 7 days, your cognitive abilities, your bodily functions, they shift to a rhythm as if you have not slept for a whole night. Okay, so that is really important. So first we'll examine some of the meta-analysis. So this was a meta-analysis, and they examined the effect of the long sleep duration on the metabolic syndrome. So they took the studies which were community-based. They compared these studies. They compared the sleep, the prevalence of the metabolic syndrome between the normal sleepers and the long sleepers. All these studies that have been included in this meta-analysis, they have followed the patient minimum for 1 year, and the design of these studies were either the prospective cohort studies or randomized control trials. And they ensured that the studies which have been included in this meta-analysis, they did not have any pharmacological intervention, because actually that can interfere with the outcome that we are looking to. So the authors could finally came with 95 articles. And what did they found? That if a person who is sleeping more than 8 hours a day or 9 hours a day, so they have included both these studies, this long sleeping hours has significant association with the all-cause mortality. And it has also these people who are long sleepers, they have higher odds for CAD or coronary artery disease, stroke, diabetes mellitus, and obesity. So these all are the parts of the metabolic syndrome. Very interestingly, they did not find an association between the long sleep type and hypertension. The authors, they did not mention any reason for this, but this was just a finding. More importantly, there was a dose effect. Dose effect means as the number of hours of the sleep they are increasing, the odds for having these kind of problems, they are also increasing. Okay. And one of the reason is that although there are some people who are constitutionally long sleeper, but when say if we talk about most of the population, they require around 6 to 8 hours of sleep. So the people who are actually sleeping long, there is a possibility that they are having some kind of sleep disorder. Okay, so that could be one reason that we have found these results. Interestingly, they also tried to find whether the effect of the long sleep duration, it differs between the genders, and they found the same results with both the genders. So the gender effect was not observed. Now, there are another meta-analysis which examined the effect of the short sleep duration. That means sleeping for less than 6 hours a night. So these, again, in this meta-analysis, the studies were community-based and they compared the sleep between the short sleepers and the normal sleepers. The design was similar to the previous meta-analysis. All the studies were either prospective cohort or randomized control trials. The no pharmacological intervention was included, given in any of these studies. So the authors could found 108 articles. And what did they find? That there was significant association with the incidental all causes mortality. We are not talking about the cross-sectional or the prevalence. So we are talking about the incidence. Incidence of hypertension is higher in short sleeper compared to long sleeper, because we did not find that in the long sleeping. Then chances for the coronary artery disease are again high. Odds for diabetes mellitus, obesity was again high. Fortunately, it was not associated with the increased odds for the stroke. So that's a maybe give us some respite. The people who are younger than 65 years, they were at more risk. Now, one of the reasons could be that as we age, the sleep time actually reduces. Total sleep time reduces and the sleep architecture also changes. So there is less of the N3 sleep or the deep sleep. There is also reduction in the amount of the REM sleep. So that also shows that the younger people, like all of us present in this hall, we actually need to have proper sleep. Then less than 6 hours was associated with the increased chances of all causes mortality. Now, there have been number of studies which have shown that the sleep deprivation can actually accelerate the death among mice. So there are a number of studies are there. Exact reason and the pathophysiology, how does it happen, why does it happen, it is not known to date. Okay. This was another paper. They tried to look at only the lipid profile in the patients who were based on the sleep duration. So they defined short sleep duration as the people who were sleeping less than 6 hours and the long sleep duration as the people who are sleeping more than 9 hours. And they did not any association with the cholesterol or HDL or the LDL. So we know that HDL is basically one of the factors for the diagnosis of metabolic syndrome. But this meta-analysis, the problem was we did the studies which were included in this meta-analysis that did not examine the lipid profile at baseline. And the lipid lowering medication, whether the patients were taking or not, it is not known. So that could actually influence the result. Other sleep disorders and depression, again, both which can precipitate or at least increase the risk to the metabolic syndrome, they were not controlled for this. Coming to other meta-analysis, which examined the sleep duration. So it includes the studies which were having the cross-sectional in nature and the longitudinal. They defined the short sleep as again less than 6 hours, and they found that the people who are short sleepers, they are at higher odds of having metabolic syndrome, not only cross-sectionally but also incidentally. And most of the studies which have been included, they had a follow-up for around 3 years. Then the same effect was found in the cross-sectional studies among the patients who were long sleepers, but no effect was found on the incidence. Now, authors, they failed to report any kind of reason for this, and they actually concluded that probably we do not have the robust and further research is required in this area. Now, coming to this sleep timing, at what time do you usually go to bed? 11, 12. Yes? 12, 10:30. Anybody going to bed at around 10 o'clock? How many of you? No one. So this is important for you. So the issue is you should always remember that we are designed as a diurnal species. Unfortunately, we have electricity, we have iPads, mobiles, computers, TVs, all this with us, and that is actually taking away our sleep. So this meta-analysis, they included it analyzed the studies which have assessed the risk of metabolic syndrome in the shift workers versus day workers. They looked at both the incidence as well as the prevalence. So they could found 38 studies, out of which 27 were cross-sectional. Studies were having retrospective design and as well as prospective design. So some of the studies, they were retrospective, and the total number of participants was nearly 1.28 lakhs. So you can see such a huge data. And what was found that the shift workers, they were having higher odds for having metabolic syndrome compared to the people who were working during the day. The female were at greater risk, and when the studies were adjusted for the sleep quality, because sleep quality is something which is we can say which is governed by the presence of other sleep disorders and the other environmental, both internal and the external factors. Because say you all know that we're getting patients who say that they are not able to sleep well, so their sleep quality is poor, though they might be sleeping for normal duration. So when the sleep quality was adjusted, even then the risk was high in the shift workers. So that means there is something wrong going in the shift work. Now, they further examined the effect of rotation. So they found that the people who were working in the rotating shift, they had higher odds. Compared to the other shift work, that means that some people might be having only the fixed night shift, fixed evening shift, or maybe the former rotating shift worker or the people who are having irregular shift. So again, this data shows that if there is a constant change in the shift, that leads to the constant change, or the regular change in the sleep-wake cycle, and that is actually detrimental with respect to the metabolic syndrome. Now, they found that the people who are working in the rotating shift for 5 years, they are having lesser odds compared to the people who were working in the rotating shift for 10 years. So there was a dose effect which was observed. Again, some of the residents or maybe say that we are having long working hours or we are not getting enough sleep. Does that increase the chances of metabolic syndrome? Yes, if you are sleep deprived. But just working for long hours does not increase the chances of metabolic syndrome. Coming to the sleep quality, meta-analysis tried to assess what is the effect of the sleep quality on the chances of having metabolic syndrome. So most of these studies were observational. Sleep quality was assessed using questionnaires like Insomnia Severity Index, Karolinska Insomnia Scale, or Pittsburgh Sleep Quality Index. Or some of these studies, they included, they assessed the sleep quality using the objective measures like polysomnography. The people who were having sleep disorders, they were excluded from the studies which were included in this meta-analysis. So authors could find 22 articles having nearly 45,000 participants, and most of the data was only cross-sectional. Next, please. So they found that the poor sleep quality also increases the odds for the metabolic syndrome. Remember, most of the patients, they were not having, all the patients, they were not having any sleep disorder. Okay? Despite that, if the person is not having good sleep at night, so that also increases the risk for the metabolic syndrome. It was much more for difficulty falling asleep and difficulty maintaining the sleep. So those of you who are going to bed at late, they should get warned that you are actually increasing the risk for the metabolic syndrome. While there was no association with the early morning awakening, because this is what it's designed for. Okay. And if you look at the next, please. If you look at most of the religions in the Asia, you will find that the first prayer is usually offered early in the morning, whether it's Muslim or maybe we talk about the Islam or we talk about the Hindu, any religion, the first prayer is usually offered early in the morning. So probably our ancestors, they knew it and they tried to relate the religion with the behavioral practices which keeps us healthy. Now, let's examine the effect of sleep disorders. Next, please. Insomnia. Have you seen patients with insomnia? How many patients do you get in your OPDs suffering from insomnia on average? Say, if you are seeing 100 patients, how many patients of insomnia do you see? 10, 15. 50% of the patients. More maybe, sir. Right. So I think, friends, you need to understand this. Next, please. When we talk about the insomnia, it is defined as a difficulty in falling asleep or staying asleep or early morning awakening, along with daytime symptoms, which are irritability, sadness of the mood, poor concentration, fatigue, lethargy, mild generalized headache. And these patients are often misdiagnosed as depression. Because as a psychiatrist, we actually always look for depression. So this article looked for the presence of the insomnia in various psychiatric disorders, and they found that more than 20 disorders that we talk about in psychiatry, we talk about anxiety, we talk about depression, bipolar, schizophrenia, substance withdrawal like alcohol, or maybe opium or cannabis, they all have insomnia as one of the diagnostic criteria. But the issue is our current understanding, I mean, current means for last 15 years, we know that insomnia is not just a symptom of any of the disorder. It is not, say, a kind of epiphenomenon occurring with the other disorder. It's a disorder in itself. Because when the patients, they have insomnia, the longitudinal studies have shown that when the patients, they have insomnia and it remains untreated, in presence of depression, substances, or anything else, in the long term, the insomnia gets dissociated from the primary disorder. And then it starts running its own independent course. So it develops as insomnia independent. So with that, the NIH came with the say concept of comorbid insomnia. And now we don't talk about primary and secondary insomnia. Now we talk about insomnia as insomnia, and that you can see even in DSM-5, it talks about insomnia as a disorder. It doesn't talk about primary and secondary things. And same in ICD-11. So another important part is it is transdiagnostic, because say we talk about the insomnia, so it shares the neurobiology with the psychiatric disorder. So we all know that the suprachiasmatic nucleus, which is the seat of for the circadian rhythms, it get influences or the inputs from the amygdala as well. It sends its output to all the nuclei present in the reticular activating system, which are important for regulating the mood and the emotions. So it's a two-way communication between them. So we cannot actually talk about, say that the insomnia is just one of the symptoms. It's probably the comorbid condition. Thirdly, there is enough data, robust data, which suggests that insomnia, if remains untreated, it increases the chances of the relapse of depression, bipolar disorder, and schizophrenia. So we have robust data, and then we have robust data regarding the relapse to substance use disorder like opium and alcohol. So this insomnia is no more a secondary phenomenon or epiphenomenon. It's a disorder in itself. Now, here comes another question. How many of you see the insomnia in patients having schizophrenia? How common is that? Very common. Now, the issue is whether it is actually insomnia or not. In patients with schizophrenia or bipolar disorder or depression, what we see may not be insomnia. So you ask the patient, okay, say if left alone, at what time do you go to bed and at what time do you wake up? We all know that schizophrenia patients, they go to bed late in the night and they wake up late in the morning. So they are sleeping for the normal 6, 7, 8 hours, but the only phase is delayed. So it might not be insomnia, it's actually delayed phase sleep syndrome, which they are suffering from and which we mistreat, misdiagnose as insomnia. Coming to the insomnia, again, we have robust evidences from the meta-analysis that insomnia increases the risk for dyslipidemia and also the cerebrovascular accident, especially if the person is having difficulty falling asleep or difficulty maintaining the sleep. Now, how common is OSA in your practice? I got a lot of patients, but how common is sleep apnea in your practice? Not much. Not much. Any idea? Right. Very true. No, this is a meta-analysis of 48 studies, and they looked for the presence of sleep apnea in psychiatry patients. And you can see that the prevalence goes as high as 50% in many patients. So the problem, what Majid is saying is very true, that we do not actually look for sleep apnea. And these patients who are having obstructive sleep apnea, they are often misdiagnosed as fibromyalgia, somatic symptom disorder, and depression. Because the symptoms are so close and so overlapping that unless we look for sleep apnea, you won't find it. Second misconception is that we think that sleep apnea is a problem of the obese people only. Always remember, sleep apnea is not a problem of the obese only. Even lean and thin patients, they can have sleep apnea, and the obese people may not have it. Because, it's not the forum where we talk about the pathophysiology of insomnia. I think I'll also get a signal from Majid. So the main findings are that OSA is not uncommon in psychiatry patients. Say, you can see here the prevalence again common in major depressive disorder, bipolar disorder, and schizophrenia. So many patients, they are having sleep apnea, but we do not diagnose them. Now, this was a meta-analysis of the OSA, which was relating to the metabolic syndrome. So they included 15 cross-sectional studies having more than 25, nearly 2,500 patients with OSA and 1,700 patients without OSA, and they found that the patients who were having sleep apnea, they were at higher odds of having metabolic syndrome. Similarly, 5 case control studies were included, and it also showed that odds for having metabolic syndrome was higher among patients having OSA. And that could be one reason why we see metabolic syndrome so commonly in our psychiatry practice, because everything we talked about, insomnia, we talked about delayed sleep wake phase syndrome, sleep deprivation, everything is common in psychiatry patients. Have you seen patients with night eating syndrome? How common are they? Not so much. Okay. Sorry, saying common, of course they are common. So you talk to the patients who are especially on the antipsychotics. They always talk that they have the major portion of their meal in the first half of the night. and during the day they don't eat much. And this is the criteria for the night eating syndrome. Maybe for the detailed criteria, you can refer to the DSM-5. Now let's examine, say we have examined the data and let's look for the possible mechanisms. So when we talk about the sleep and the endocrine, we all know that there is a circadian master clock in the suprachiasmatic nucleus. So it gets entrained every day from the light that falls on our retina. We all know that. But it is not only the light which entrains the SCN. Other things like at what time you are eating your meal, your exercise time, your social activity, your mood, your emotions, they all actually entrain the suprachiasmatic nucleus, your master clock. And this master clock in turn controls all the clocks in the periphery. So every cell in our body, it has a say circadian rhythm, which is getting controlled finally by the suprachiasmatic nucleus through the melatonin. And this is important so that say an animal or the person who is say his feeding rhythms, his drinking rhythms, his locomotor rhythm, they all come in cohesion with his sleep-wake cycle. So this is the importance of this is that. Now, so let's examine certain hormones. So we all know that there are certain hormones which are regulated and linked by the sleep and the sleep timing. So what happens in the early night, there is an increase in the leptin, and we all know that leptin is a hormone which gives you a signals of satiety. If you are not sleeping by this time, you are missing this peak of leptin. And you must have realized that when you are staying awake till late night, you always have a kind of urge to have some kind of food. And you will never prefer any kind of salad or fruit at that time. You have an urge for the food which are rich in carbohydrate and fat. And this is because of the say discrepancy in the levels of the leptin and the ghrelin. Ghrelin is another hormone which is secreted by the stomach and it increases the appetite. So it increases by this time. Similarly, there are multiple other hormones like growth hormone, cortisol. They also get secreted by during the sleep, and we all know that the growth hormone peak level is around in midnight, and the cortisol peak level is in the morning. So if you are sleeping late compared to the environmental timing, these rhythms get disrupted. And that leads to the disruption in the metabolism of not only the glucose, but also the fat as well as the proteins, and makes you prone to develop metabolic syndrome. Okay, coming to the night eating syndrome. So it has been found that the patients who are having night eating syndrome, their melatonin rhythm is delayed, their ghrelin rhythm is advanced. So the meal that they should have in the breakfast, they try to have it early in the night or in the middle of the night. And their glucose rhythm is antiphase to the control. Normally what happens in the night, the glucose level goes down for many reasons. One, we do not take food, then there is consumption of the glucose during sleep, the insulin is high, which transfers the glucose in the cells. So we are having relative hypoglycemia during the night. So in the patients who are having night eating syndrome, the glucose is actually high in the night. And there is reduced amplitude of both the ghrelin and the insulin that further changes the feeding cycle. Okay, and that increases the preference for certain foods. Now we talk about the misalignment. I think you all know about the advanced sleep-wake phase disorder and delayed sleep-wake phase disorder. So maybe I think we can skip that. So when it comes to the circadian clock, when we look at the molecular mechanism, the circadian clock is basically governed by a negative feedback loop. So we have clock and BMAL, which enhance the production of purr and cry throughout the day. And this purr and cry protein, it gets accumulated in the cell cytoplasm throughout the day. When it reaches a critical level, it shifts to the nucleus and it reduces the production of the BMAL and the clock gene. So it represses that. So that way we actually fall asleep. Okay, so this is one of the basic simple clock. Now, the result has shown, the genome-wide association studies have shown that nearly 6 to 10% of our genes, they actually express in a circadian fashion. And most of these genes are related to the metabolism. Okay, so that again shows that there is a link between the sleep timing as well as the metabolism, and certain of these genes, they actually further control the aging as well as the cancer. So there is robust evidence that if you are not sleeping on time and you are say you have misalignment with the circadian rhythm, that the chances of at least 2 cancers, we have robust data, prostate cancer in males and the in females, the breast cancer, it increases tremendously. Now, the circadian clock genes that we were talking about, the cry and the purr, they do not only act on the clock and the BMAL genes to maintain the circadian rhythm, but they also act on the other factors which are important for the controlling the metabolism, which control the ketogenesis, glucogenolysis, gluconeogenesis, fatty acid production, and so forth. And one of the important part in this is sirtuins. I think you must be knowing about sirtuins. Sirtuins are the specific genes which actually are getting controlled by the cry and the purr, and which interact with the clock and BMAL to increase the expression of NAMPT, which is important for the say energy production. So whatever energy we are taking and how much we are losing as the basal metabolic rate. So this NAMPT is important for that, and if you are not sleeping on time, this gets disrupted, and your body tends to accumulate whatever you are eating. So your expenditure goes less. And say the experiments have shown that if you are delaying your sleep by 4 hours just for 3 days, the rhythmic genes which get rhythmic transcription, their proportion goes as low as 1%. And these all genes, they are important for the aging, cancer, as well as the metabolic parameters. Then when you are sleep restricted, you have increased chances for the food intake. You have a hedonic feeling to eat more food. Then your ghrelin increases, leptin goes down, your fatigue increases, which reduces the exercise. You increase your time awake, so you have higher chances to have food. And then your sleep quality decreases, which is again a risk factor for the stress, and that stress again leads to the cortisol activation of the HPA axis, and which further accumulate, increase the chances of developing the obesity, especially the central obesity, that the apple type of obesity.
Hello, Dr. Ravi. Sorry to interrupt. Now we need to wind up the things.
Sure, sir. Just give me 2 minutes more, sir.
Thank you.
So what has been found that the sleep restriction in healthy population, it alters the cognition. So it increases the salience for the food stimuli. You have lesser control over the food. So if you do not, you know this information, but you want to control yourself, that I won't eat, you won't be able to control it. And the preference for the food that helps in gaining weight, and there is a reduced insulin resistance, and the effect is dose dependent. That is, the people who are having total sleep deprivation, they are at higher risk compared to the people who are having partial sleep deprivation. Next, please. Next, kar do. Now, this is another study that we did, and we tried to look whether the sleep apnea, which is common in patients with schizophrenia, whether it causes the metabolic syndrome. And we found that it was basically the sleep apnea which was, increasing the odds for metabolic syndrome in patients with schizophrenia. So that is a really important issue that we need to consider, and we need to examine the patient with schizophrenia for sleep apnea. Good thing is, at least in healthy controls, these effects of the poor quality sleep, the lesser sleep, or sleep deprivation, they are reversible. But what happens in the population who are having other sleep disorders, we do not know. So these are some of the areas where further research is required. So to summarize, I can say that if you are not sleeping well, if you are sleep deprived, you are sleeping too long or sleeping less, or maybe you are having some kind of sleep disorder, then you are at higher chances of having the metabolic syndrome, and most of the pathways that we have already discussed. So finally, the take-home message is sleep well, and the equally important is that you sleep on time. Thank you very much.
Thank you, Dr. Ravi, for this excellent and wonderful presentation, as always. And I welcome you again. I think you are here in Srinagar, second time in a month. Am I audible? Is everybody listening to me?
Yes.
Okay, thank you. So we have actually a lot of questions for you, but most of the questions I think you have already deliberated on your topic. We had a question from Dr. Ajmal, Dr. Javed Iqbal. They have been already deliberated. What is the link of metabolic syndrome in patients suffering from insomnia and OSA? Correlation between chronicity of sleep disturbances, apnea, hyperapnea index in OSA and development of metabolic syndrome? And are there any studies related to development of metabolic syndrome in night shift workers? So I think you have already deliberated. Well, and I would like that brief answer so that I can take all the questions. We have Marcelina Akhtar saying the role of modafinil in metabolic syndrome. Ravi?
Sir?
Role of modafinil in...
Okay, sir, as of now, we do not have any data regarding the role of modafinil in treatment or managing the metabolic syndrome.
Okay, thank you. Sabah Yunus, does sleep change in pregnancy predispose a pregnant lady to metabolic syndrome? And
Yes,
what psychiatric implications could I have in the patient?
No, of course, the sleep changes that occur during the pregnancy, they increase the chances of having metabolic syndrome. We have some data regarding that.
We have Dr. Goza saying post-graduation was supposed to give night shifters aspiration surgical branch. Are there long duty hours on a stretch? What is the long-term outcome on mental health and sleep cycles?
Sir, I'm sorry if I'm not wrong. You are talking about long duty hours and effect on metabolic syndrome.
Actually, you have already taken this. Yes.
Okay. Mental health, well, I'm not really sure, but I think you will be having signs of sleep deprivation. So that can actually increase the chances of having depression and the anxiety and substance use, all the three.
We have Alia Khanam saying, sir, is there any association between visceral adiposity and duration of sleep?
Distal adiposity and duration of sleep, of course, I mean, there is no data as per my knowledge. There could be some literature, but yes, we have the relationship between the central obesity and the sleep, and that we have already discussed.
We have Sarid Mahavish who says that lithium is found to increase the length of circadian rhythm. What will be the influence on the body in this regard? Any links on its route to metabolic syndrome? Lithium and metabolic syndrome.
Sir, to my knowledge, I'm not aware of any data if that exists regarding the association between the lithium and the metabolic syndrome. But yes, there is some data regarding the bipolar disorder and the metabolic syndrome.
Okay, Dr. Deba is saying, is there any study done on the impact of shift work, short sleep on junior doctors' health, and shift work which leads to circadian disturbances?
Yes, of course, there is a good data regarding the sleep disturbances and the sleep deprivation among residents, and what kind of most of the data actually it correlates with the errors they make when they are taking the medical decisions. To my knowledge, there is no data regarding the risk of metabolic syndrome and the sleep deprivation among medical doctors.
We have Sabah Yunus again asking a question. Does PCOS predispose the patient to sleep changes? And if yes, what implication will it have on the prognosis of PCOS?
Yeah, PCOS patients actually they have higher risk for having sleep apnea because of the multiple reasons, the gain as well as the hormonal changes, especially estrogen and the progesterone. And so there are a number of studies and there are meta-analysis suggests that the patients with the PCOS should be screened for presence of sleep apnea, and whenever possible, it should be treated.
Okay, thank you. We have Syed Mahesh again with a question. Can we improve metabolic parameters in patients of restless leg syndrome by prescribing iron or any other drugs?
Well, we do. There are certain data regarding the cardiovascular effects of the restless leg syndrome, but again, that data is again not very robust. To my knowledge, we do not have any robust study which talks about the metabolic effect. But yes, there is a possibility, and of course, the treatment of RLS will improve the sleep. So at least theoretically, it will reduce the chances of having metabolic syndrome.
I think we have lost two questions here, just brief answers for them. Dr. Deepa is saying treatment-resistant insomnia, prevalence and management. I think this will be a very long answer.
Well, I think this is a new term that I have heard today, treatment-resistant insomnia. I mean, at least in the sleep literature, it does not exist.
But there are many patients who actually don't improve with any of your drugs. They still have insomnia.
Sir, the problem is, say, we did the study of the patient. Yeah. Sir, it is always good that when you are having a patient with chronic unexplained insomnia, get a polysomnography done, because times we see that these patients are actually not having insomnia, but they are suffering from central sleep apnea or periodic limb movement disorder or some other sleep disorder. Many times these patients are also having, if you look at meta-analysis which was published last year in Sleep Medicine Reviews, it clearly says that as much as 40% of the patients with chronic insomnia, they have comorbid OSA. And this remains untreated, and that could be one reason that the patients, say, the doctor is talking about the chronic or maybe treatment-resistant insomnia. So I think there is a need to look for the underlying reason and the other sleep disorders that can disrupt the sleep.
We have one last question now from Dr. Ashish. Patients with psychiatric disorders major of the time have insomnia and metabolic syndrome. If we consider insomnia by giving medication, can we cure his metabolic syndrome to avoid polypharmacy?
Okay, sir, I really do not have any answer for this because we do not have any data regarding it. Whether the treatment of insomnia in psychiatry patient can cure metabolic syndrome, but yes, definitely can reduce the risk.
Thank you.
Thank you, sir. Dr. Majid.
Thank you, Dr. Zahid. Thank you very much. Thank you very much. Before we conclude, last comments from our chairperson, just brief comments. Dr. Brahma, you are still traveling in Kolkata street?
Yeah. No, I'm going to the district in the highway. Thank you, Dr. Gupta. It's a very nice deliberation. And as you have mentioned, the different sleep disorders, sleep quality, importance of sleep timing. So it's good to learn. And especially the insomnia, it is now considered as a diagnosis itself, not only a symptom. So I think all the PG students, they have learned a lot, and we know that there is a good correlation between these sleep disorders and the metabolic syndrome. So thank you once again, Dr. Gupta, for your very nice deliberation. Thank you.
Thank you very much. Before I go to Dr. Manish, Dr. Zaid can till then finalize the best question that has been asked. Dr. Manish, can you share your thoughts briefly?
Yes, sir. It's a wonderful, as I said, two speakers all overlapped one over the other. Who else other than Dr. Ravi can say polysomnography is a very underutilized tool as per if we talk about the psychiatric patients. And very rightly, treatment resistant is a term that exists in psychiatric literature. It's not a term that exists in when we talk about, we don't have anything called as treatment resistant metabolic in endocrinology. Hope Dr. Jubin comes next. He has an answer to this. Or we don't have anything like treatment resistant in sleep medicine. So as I would concur with sir, we are missing out some things either from our history or investigations to reach to an adequate diagnosis. It does exist. OSA does exist in psychiatric patients. RLS does exist. Only thing is either we missed out in our history or we are, what it says, ki eye sees what the mind knows. So probably we need to look more into our brain to get an idea of what our eyes wish to see that. Thank you, Ravi sir. It's always wonderful to have a talk from you.
Thank you very much, Manishji. Dr. Satish Verma, any last thoughts before we wind up the session?
Yes, Dr. Ravi, congratulations. You have very well covered this difficult topic of sleep and metabolic syndrome. We need to learn from you. Like we are getting patients of insomnia daily and which don't sleep at all. And sometime later we listen from you on insomnia, on how to investigate it. Thanks so much.
Thank you, Dr. Zad. Can you?
Dr. Margin actually is a very difficult job which you have given to me. And I think the best person to answer this, what was the best question is Dr. Ravi. He is standing there. He should know what was the best question. And he has answered rapid fire. So he should actually answer that question.
You have conflict of interest as well. I understand that.
Exactly.
Dr. Ravi can address himself. You have any? We can do it later on. Maybe other chairpersons can give inputs and we can do it.
I think he can just.
Yeah. Thank you very much. Thank you very much. Thank you. Before we wind up, we will like to. Dr. Jitendra Aneja, anything to say? Ask if you are there. Dr. Aneja.
Thank you, sir. I think it was very inquisitive talk and many postgraduate will benefit. This area is very less talked about and I think the psychiatrist should focus on this area of research also. Thank you.
Thank you very much. Thank you all. And it's time for felicitation of our speaker and chairpersons. Obviously, chairpersons are online. So they will get their mementos in due course of time. But we have Professor Nimesh Desai, who is the Director IBHAS. I would like sir to come forward and felicitate our dynamic speaker, Ravi Gupta. I had an honor of working with Dr. Ravi Gupta for clinical practice guidelines of obstructive sleep apnea for Indian Psychiatric Society. So he is my teacher. In 2017-18, we had written clinical practice guidelines for OSA in Indian Journal of Psychiatry. Thank you very much, Ravi, as usual, for a very interactive and very nice talk. And we always love to listen to you. And we move on to the next session, which is by Dr. Jubin. I can already see on the screen. Dr. Jubin Jacob, he is from CMC Ludhiana. He is an endocrinologist. And we have three eminent chairpersons with us. We have Dr. Preeti Arun Madam, who is professor and head Department of Psychiatry, Government Medical College, Chandigarh. We have Professor Vedpal Mehla sir. He is always active on these forums and otherwise also in community outreach. Then we have, last but not the least, Professor Tushar Jagawat, who is immediate past president of Indian Psychiatric Society North Zone. And to moderate the session, may I request Dr. Junaid Nabi, who is assistant professor in Government Medical College, Srinagar, and he is a dear friend. Please go ahead, Dr. Junaid, to introduce the chairpersons.
Thank you so much. Good morning, everyone. I hope everyone is having a wonderful time over here and getting wiser with the wonderful presentations and enjoying sunlight, which is just come out. So I would like to introduce three eminent chairpersons. Let me introduce Dr. Preeti Arun ma'am. She is a professor and head of psychiatry at GMC Chandigarh and joint director, Government Rehabilitation Institute for Intellectual Disabilities, additional director, Mental Health Institute. Being a pioneer member of the department, ma'am has been involved in most of the special clinics run by the department. Currently, ma'am is in charge of Child Guidance Clinic, Autism Clinic, and Disabilities Cell of the Institute. She has numerous national, international publications and book chapters. She has received Dr. Bakshi, Dr. A.K. Kala, and many other awards in psychiatry. Ma'am is associated with many NGOs like Umeed, Samarth Jio. Welcome, ma'am. I will also like to introduce Dr. Tushar Jagawat sir, who is a senior professor and head, Department of Psychiatry, NIMS University, Medical College and Hospital, Jaipur, Rajasthan. Sir has been past president IPS North Zone. Sir has been past president IPS Rajasthan and also past President Delhi Psychiatry Society. Sir has been Executive Council member, Indian Association for Child Psychiatry. Sir has written Hindi poetry books related to mental health and de-addiction. And one of the famous is Mananjila, which is a famous book. I welcome you, sir. And third is another eminent speaker, Dr. Vedpal Mehla, sir, who is a senior professor and head of the department at GT Medical College Hospital, Guregaon, Delhi. Sir has a vast experience of 35 years in psychiatry and has developed vast and varied skills as a teacher, researcher. His areas of interest includes ECT, forensic psychiatry, community psychiatry, suicide prevention, and TOBO and stigma related to psychiatry. Sir is international member ambassador API since 2014, has been awarded certificate of recognition and appreciation for achievement as an APA international membership ambassador in 2014. Sir is life member in IMA, life fellow in IPS International Fellow American Psychiatric Society. Sir has many national and international publications. I welcome you, sir. So, now, not taking more of the time, I will hand over mic to the chairperson so that this session can be started at the earliest. Thank you so much.
Dr. Iti,
Yeah.
you please introduce the speaker. Yeah.
So it's actually really wonderful to introduce Professor Jubin Jagan Jacob, and it's welcome to this postgraduate development program. Dr. Jubin is professor and head Department of Endocrinology of Christian Medical College, Ludhiana, and he is executive editor of IJEM. He is member of Institutional Research Board. His international fellowship at JJR McLeod Center for Diabetes and Endocrinology, Aberdeen, United Kingdom, from 2012 to 14. He is also honorary lecturer at School of Medicine and Dentistry, University of Aberdeen. He has authored 3 books, which are all very relevant: Endocrine Disorders in Pregnancy, Diabetes in Women, and Clinical Update on Management of Diabetes mellitus and Complications. He has over 100 national and international publications. So welcome, Dr. Jubin, and thank you so much for being here. So please start with it.
Thank you. I'll start sharing my screen. Is that visible? Is my screen visible?
Yeah.
So thank you, chairpersons. Thank you, Dr. Preeti. Thank you, Dr. Sandeep Goyal, for inviting me for this postgraduate development program of the North Zone of the Indian Psychiatry Society. So I was given this talk of managing diabetes mellitus, and then I understood I have to talk about lipid disorders as well, and among patients with severe mental illness. I thought this was not a word that we commonly use, mental illness, but I understood that this is actually a term. So I had to actually search literature for what exactly we mean by severe mental illness. And I understand that this, I'm sure all of you don't require to know, but I wanted to find out for myself, what am I dealing with when I say severe mental illness? I understand these are significant psychiatric comorbidities like bipolar disorder, schizophrenia, and psychotic depression. So if I'm wrong, you may correct me. But what I did understand when I read about severe mental illness is most of these patients have a 2 to 3-fold increased risk of mortality. And that means that these are patients that are going to have a life expectancy that is 10 to 20 years less than a similar patient who did not have this disorder. And then I understood that, other than what we would think an increase in trauma and suicide, primary reason for most of these mortality or excess of mortality is actually cardiovascular death, which is an area where we do a lot of try and prevent a lot of cardiovascular death, because we are dealing with metabolic syndrome, not in severe mental illness, but in usual normal patients. We are dealing with type 2 diabetes. We are dealing with patients with chronic kidney disease. And cardiovascular death is a consequence of excess of type 2 diabetes, a lot of weight gain and lipid abnormalities, hypertension. And I was hearing the previous speaker talk about obstructive sleep apnea. I'm sure all of that is growing in the same soil, which is what is responsible for the excess in CV deaths. So I was just, when I was preparing this, I recently thought about one of my patients. So this was a 46-year-old. He stays very close to where I work in CMC Ludhiana. Fieldganj is a place very close to our hospital. He's had severe schizophrenia under treatment for almost all his life. I'm not sure, maybe 20, 25 years. He's been a patient of type 2 diabetes since 2005. So this is when he developed it around the age of 30. And since 2009, he and his mother have been my patients for type 2 diabetes. What I was very shocked to hear recently when his mother came and told me that he passed away, and what it looked like, he passed away because of a cardiovascular disease. And then I realized that he has been my patient for almost 11, 12 years, but he has visited my clinic probably only about 4 to 5 times in the last 12 years he was my patient. So most of the time his mother used to bring some reports to me. She'll show me some reports. She'll say that he's okay, he's eating too much, he's not eating anything. And I would just give her a prescription proxy for this gentleman. For many, many years I've been doing that. I don't think I've seen him for the last 4 or 5 years, though I've been giving him prescriptions repeatedly because his mother used to come and visit me in the clinic. So what I did realize is that I did not follow any of the standard of care that I would have followed for other patients, primarily because he was not visiting me. He was not under my radar. I never screened him for lipid disorder. I'm sure in the last 3-4 years, he never had a blood pressure taken because he was he was not willing to come to the hospital, and his mother was taking care of him by just telling me what he was up to. So this brought me to this whole question of how do we treat patients with severe mental disorders? And then I realized that it's not just in Ludhiana that we did treat the metabolic problem of this patient a little poorly. It is a common thing that patients with severe mental illness are less likely to get routine screening for metabolic disorders. This is a paper from Canada, from Ontario, which suggested that there is only about 25% normal people who live with undiagnosed diabetes, but with patients with schizophrenia, almost 70% are living with undiagnosed diabetes. So this what was the highlight of this paper. So I realized that this is not just something that I have encountered. This is common, and this happens that patients are not screened. Patients probably do not get the standard of care. And I hope by the end of this talk, because many of these patients are not going to visit endocrinologists, not going to visit physicians, they are going to visit psychiatrists, and that may be the only extent of physical screening that they might get. So hopefully by the end of this talk, I hope that some of these issues may be dealt directly because these patients may not come to us. So just a little bit about the pathogenesis, and I think this is a very good review on patients or treatment of diabetes and severe mental illness. Dr. Rory Holt has published this in about 2014 in Nature Reviews on Endocrinology. And what he suggests is that the antecedents of both type 2 diabetes and severe mental illness are fairly common. Poor diet, poverty, deprivation, genetics, inflammation, and all of these things are fairly common with severe mental illness and type 2 diabetes. On top of that, once patients develop these severe mental illness, they are going to have poor diet, poor physical activity. They also, I'm sorry that the last box is not seen, but they're also likely to have addictions like tobacco, alcohol. And then there is a whole issue of the metabolic problems that accompany the use of drugs for treating severe mental illness, antipsychotics. I'll not discuss in detail about antipsychotics and the risk of diabetes because I'm sure you are all very well aware of it. But all of this primarily impact our metabolism by increasing weight. So it is obesity that is the reason for type 2 diabetes, and we've seen that there are common antecedents also. How common is it? How common? Now I was looking at what it would be like for Punjab. So this is an area where I have a fairly good knowledge of the epidemiology. One of the reasons why we know how many Punjabis have type 2 diabetes is because we have done some work in epidemiology. We were part of a large ICMR in-diet study. So what we found in 2016 was 10% of adults, both in rural and urban Punjab, are likely to have type 2 diabetes. So we already have a baseline. That means even among patients who have severe mental illness, there is already a baseline risk of type 2 diabetes that is about 10%. So this is via family history, obesity, diet, exercise, all the risks that you and me also have. On top of that, the severe mental illness is going to result in poorer diet, addictions, poorer physical activity. And this is now my conjecture. I don't have data on this, but from literature, what I understand is this is going to double whatever your baseline risk of diabetes is. So that means in Punjab, I would expect 20% of patients with severe mental illness to have type 2 diabetes, while without severe mental illness, it's about 10%. Now, on top of that, you add typical, atypical, any kind of antipsychotic therapy, and that is going to increase the risk another 10% more. So my guess is around 30% if the data about severe mental illness and diabetes holds true for Punjab as it holds true for developed countries as well. You expect about 2 to 3-fold more increase than whatever your baseline risk of diabetes is. So you'd expect that patients with severe mental illness in Punjab to have about 30%. This is adults over the age of 30. So when should we screen? So that means there is a significant 3 out of 10 patients with severe mental illness are likely to have type 2 diabetes. So how should we screen them? So I think this is again from the expert reviews. This is no guidelines, but my guess is at the diagnosis of severe mental illness, everyone should be screened for diabetes and lipid disorders. When you start a new drug, especially when you change a psychotic, you change the type of psychotic, I think antipsychotic drug that you're using, I think that is again a point where you should screen for diabetes and lipid disorders. 2 months after starting a new drug, I think there are enough data that suggests that many patients react differently to new drugs. So that is a good time point again to check for both diabetes and lipid disorders. And then subsequently, at least in normal routine population, we say once in 3 years you should screen. But I think in patients with severe mental illness, at least once a year thereafter, we should be screening them for diabetes and lipid disorders. So I think this is a reasonable expert opinion, not my opinion. This is published expert opinion regarding how frequently we should screen these disorders. And how to screen, again, this becomes a challenge because we know the gold standard is oral glucose tolerance test, which may not be feasible for most patients with severe mental illness. So the minimum we should do is probably what we call a casual plasma glucose, also called random blood sugar. That is the minimum you should do. At any point you find the random blood sugar is more than 200 or the patient has symptoms and it is more than 200, you should definitely get a fasting plasma glucose. I'm sure all of you are aware that the current ADA or the WHO guidance for diagnosing type 2 diabetes is a threshold of 126. That is for diabetes, and anything between 100 and 125 is considered to be pre-diabetes, and normal is less than 100. So this I'm sure most of you know, but I think what is now more useful, and I think that is a test that may probably will be underutilized among psychiatrists is the use of HbA1c. Now, HbA1c has an advantage that you don't need the patient to come fasting. I'm sure patients with even normal patients, routine patients without severe mental illness, I find them difficult to come fasting to the hospital. But I'm sure patients with significant mental illness will find it even more difficult to come to the hospital on fasting. So HbA1c is a test that can be done at any time in the day, at any point in the day, and currently the threshold for diagnosing diabetes with HbA1c is more than 6.5, and between 5.7 to 6.5 or 6.4, it's considered pre-diabetes, and less than 5.7% we consider normal. I think I need to give a caveat that all HbA1cs are not equal. That means if you are using HbA1c to screen, please use HbA1c from a good laboratory. And when they say good laboratory, they should note below the HbA1c that this is done by a method which is NGSP certified. So that is very important. The standard, there are many cheaper HbA1c tests available in the market which are not NGSP certified. So you cannot use those HbA1cs to make a diagnosis of diabetes. So if you're screening diabetes with HbA1c, use something what was called the NGSP certified. And if you look at various lab reports, the good labs will tell you whether it is NGSP certified or not certified. Oral glucose tolerance test is obviously very, very difficult, even in routine care. So I'm sure in patients in psychiatry practice, this is going to be a difficult screening tool. Now, can we prevent diabetes? And I looked at literature for this, and I found there were no studies that looked at preventing the occurrence of type 2 diabetes in patients with severe mental illness or patients who are prescribed antipsychotics. But there are papers which looked at preventing weight gain or trying to reduce the weight gain in patients who are prescribed antipsychotic, and lifestyle measures. This is a very large meta-analysis published in 2012, looking at lifestyle measures and trying to prevent weight gain. And it is slightly disappointing that in this meta-analysis, you can see the loss or the difference in weight in those who had these lifestyle measures was only about 3 kgs. And this the drawbacks of this is that most of these studies were small studies, few weeks, not more than 24 weeks. These were more successful in outpatients, not at all successful in inpatients, and the cost of intervention was quite steep. To keep the patients on these lifestyle modifications, the cost was steep. So this is really not going to be a very useful way of prevention, and there are only very few studies which have gone up to 1 year, and they have not shown the same kind of benefits that the smaller studies have shown. Are there drugs we can use in patients who are prescribed antipsychotics to prevent diabetes? Again, the answer is no. We have not found any drugs. There is few studies of use of metformin in patients who are prescribed antipsychotics for primarily reducing weight gain, not for prevention of diabetes. And here, this is another meta-analysis looking at metformin as a drug for preventing weight gain in patients with severe mental illness. And I'm sorry, I have not put the reference for this. This is also, I think, in schizophrenia research published in 2014. Again, the difference in weight was only about 3 kilos with the use of metformin. And again, no long-term studies, no studies looking at prevention of diabetes. So really nothing currently that are available which will help you prevent diabetes other than keeping on explaining lifestyle measures as a way to prevent weight gain. And by preventing weight gain, we hope to prevent some of those increased risk of diabetes from blooming. With this, I'll go into management of type 2 diabetes. I'll again quote Dr. Richard Holt here, saying that management of type 2 diabetes in people with severe mental illness is very similar to managing the condition in the general population. And we should follow current available treatment guidelines. That makes it very easy. There is nothing different in managing diabetes among these patients compared to what I do in my regular outpatient practice. So I follow the current, so I'll discuss the current treatment algorithms and tell you what I usually do for patients without severe mental illness. And this is exactly the same things that you need to do with patients with severe mental illness. The only caveat is here, most of the patients are expected to gain weight. So if we are using oral agents, we should tend to use oral agents that are beneficial or that might help in reducing weight. I'll discuss some of the oral agents that help in reducing weight in the subsequent slide. So with this, before I go into the guidelines, just to highlight what the traditional idea about pathogenesis of type 2 diabetes is, the three markers or the unholy triumvirate which we consider as insulin resistance, beta cell dysfunction, and an increase in glucose production from the liver. This is the three main pathophysiological inputs that lead on to type 2 diabetes. Here you can see the yellow and the dotted graph that there is 4 to 7 years of impaired glucose tolerance before patients develop frank diabetes. Now, this is for regular patients. Patients on antipsychotic, all this might get much reduced. So you might have patients on antipsychotic having impaired glucose tolerance for 6 months, 1 year before they develop frank, full-blown type 2 diabetes. So this is much more faster in patients with severe mental illness, especially in the presence of antipsychotics. And here you can see insulin resistance is very important that accompanies obesity, that accompanies weight gain. Along with insulin resistance, you can see when you get more and more resistance, you compensate for that resistance by making more and more insulin. So at the time of diagnosis of type 2 diabetes, you generally have what we call a hyperinsulinemia. This is despite the fact that beta cell function is low. And then subsequently, as there is decline in beta cell function, which is seen here in the purple line, by the time you're diagnosed, you already only have about 50% of your beta cell function. And when that subsequently declines, the hyperinsulinemia will also decline, and the blood glucose values and the hepatic glucose output will keep going up. So this is our traditional understanding of pathogenesis, but we have now realized in the last 15 years, I think this term ominous octet was coined by one of our gurus in endocrinology and diabetes called Dr. Ralph DeFronzo. He's about 80 years old. He coined the term ominous octet in 2008, where what we thought was the triumvirate was we really understood that there are many other things, that it's not just insulin resistance, not just beta cell function, there is fat problems, there is gastrointestinal tract problems, there is kidney problems, there is problems in the alpha cells of the islets, and type 2 diabetes is also a neurological disease. So with this, because understanding this is important, because many of our new drugs or the drugs that we have now in the last 15 years utilize some of these pathophysiological defects or trying to address some of these pathophysiological defects to get glucose control. So first of all, I'll look at what is considered the incretin effect. And I'm not too sure how many of you have heard about it, but if I'm sure the postgraduates, if they have done MBBS recently, they would have heard about incretin effect. It is now in all pharmacology textbooks. It is a very unusual thing. The incretin effect essentially is that if I give somebody 100 grams of glucose orally versus the 100 grams of glucose intravenously, logically it would seem that intravenous glucose should produce more insulin, but it is not that way. It is oral glucose which actually produces more insulin in response. So same amount of glucose, but when given orally, there is more production of insulin from the beta cell. And that primarily happens because in response to food in the stomach, there are these two hormones that are released from the GI tract, and these are called incretins. They are GIP and glucagon-like peptide 1. So these are two peptides which are released in response to food in the GI tract, and in turn, that incretin effect will lead to what we call insulin secretion. So there is a glucose-mediated insulin secretion from the beta cells in response to these incretin hormones, and also there is a suppression of glucagon from the alpha cells. So that also helps in reducing hepatic glucose output. So both ways, the GLP-1 and GIP, which is secreted in response to food, will improve production of production of insulin from the beta cell and reduce glucagon from the alpha cell. And that is the reason why oral glucose produces more insulin, because now you have the glucose itself driving some amount of insulin secretion, but augmented by the presence of incretins from the GI tract. And incretins have a very short half-life. These two hormones that we talked about have very short half-life, and they are removed from the circulation by an enzyme called dipeptidyl peptidase, or DPP4. And that is why we have drugs now which inhibit this particular enzyme. We call them DPP4 inhibitors, and that helps in prolonging some of the action of GLP-1 and GIP-1. So this is a good benefit for patients, but unfortunately in type 2 diabetes, some of this physiology is also interrupted, in addition to insulin resistance and beta cell dysfunction. There is decrease in the production of GLP-1 and GIP-1 in type 2 diabetes. So that is why drugs that work as GLP-1 agonists or as DPP-4 inhibitors lead to good responses or good efficacy in terms of glucose control. The other thing that we now understood is that the alpha cells, which we did not give much importance to, is equally important, because in diabetes, we know that there is beta cell dysfunction, there is decrease in the number of beta cells, but the cells that compensate or hypertrophy is the alpha cells actually. So there is hyperglucogonemia in type 2 diabetes, which drives glucose production by gluconeogenesis from the liver, and that is the reason for high fasting glucose that you see in patients with type 2 diabetes. And finally, I'm sure in physiology, most of you know that kidneys can filter glucose very efficiently. Almost 180 grams of glucose reaches your kidneys every day, and 100% of this is reabsorbed. That means you do not get any glucose in the urine, because it is very, very efficient. The nephrons are extremely efficient in reabsorbing glucose back. So we have two transporters that are responsible for this. In the proximal tubules is a transporter called SGLT2, which reabsorbs 90% of the glucose that is filtered. And in the distal tubules, we have SGLT1, which is also a transporter, sodium glucose link transporter 1, which reabsorbs the remaining 10% that reaches the distal part of the tubules. So this is good. We don't lose any glucose. We have no glucose coming in the urine, but we found that in patients with type 2 diabetes, this whole response is maladaptive. All of us in physiology, we learned that the threshold for glucose excretion in the urine is about 180 milligrams per deciliter. If your glucose crosses 180 milligrams, you start getting some amount of glucose in the urine. But what happens in type 2 diabetes is not that the threshold goes down. It's the threshold goes even more further up. So that means in patients with type 2 diabetes who already have sugars of 200, 240, the threshold goes up beyond 180 to 220 to 240. That means there is maladaptation of the kidney to hyperglycemia with increase in the threshold of glucose excretion. That means the kidneys are now keeping back. We already have high glucose, and the kidneys are keeping back all the high glucose. And that is the reason why we have drugs now called SGLT2 inhibitors, which inhibit this reabsorption. So they will lead to glucose wastage in the urine, and that way help us in both losing calories, help us with obesity, and also help us with management of hyperglycemia. So when we talk about hyperglycemia, most of our reason why we focus on hyperglycemia comes from a very large study in the United Kingdom. We call it UKPDS, or United Kingdom Prospective Diabetes Study, where we found that by reducing HbA1c by 1%, we do reduce significant microvascular deaths and macrovascular complications. So that is the reason why we realized that it is not just symptoms we should be concerned with. Reducing HbA1c by 1% gives us all these benefits in long term. And then we realized that there is a threshold to these benefits, that when we further decrease HbA1c to 6%, the risk of hypoglycemia negates any of the benefits of better control of glucose. So that is the reason why for most patients, we have a treatment goal of 7%, which is what we should attain. And if we can get even lower down without hypoglycemia, we can try and attain as low as possible. So this is the reason behind our goal. And to achieve the goal, We have guidelines, and the most widely followed guidelines are the American Association of Diabetes and the European Association of Study of Diabetes. Both of them come together and give us a guideline once a year on how to use oral agents and when to start insulin for type 2 diabetes. So these are all for type 2 diabetes. You have to remember, in severe mental illness, there is no increased risk of type 1 diabetes, but you might rarely have type 1 diabetes with severe mental illness, but the risk of increased risk of diabetes is predominantly or 100% type 2 diabetes in patients with severe mental illness. So you can see what has not changed since 2004, the last 16 years. What has really not changed is that the first line therapy for all types of type 2 diabetes, whether you are a normal weight type 2 diabetes and overweight type 2 diabetes, the first line therapy for all patients with type 2 diabetes is lifestyle intervention. And lifestyle intervention includes weight management, cutting down on calories, diet control, increasing physical activity, exercise, reducing sedentary activities, and cutting down or stopping smoking, using alcohol in moderation. So these comprehensive lifestyle is common and is the first line therapy for all patients with type 2 diabetes. Along with that, we have metformin. Now, metformin is a drug that we would use for all patients with type 2 diabetes, and it will remain the drug of choice, the first drug to be used even in patients with severe mental illness. And the reasons for that is easy. Metformin was the first drug which showed that, it gave you benefit because of glucose control, the 1% HbA1c benefit, which had, but additionally, metformin was a drug which gave additional macrovascular benefits in terms of death, myocardial infarctions. And there was something also seen in the UKPDS, which we call metformin memory. That means patients who were getting metformin for 10 years, even when we stop metformin, they continue to have benefits of metformin that they received previously. And that is the reason why, despite all the newer drugs that have come, all the dramatic improvements that they have brought, we still consider metformin as the first line drug for every patient with type 2 diabetes, regardless of whether he has severe mental illness or he does not have. So this is a protocol for metformin dosage. I think important to remember here is metformin is very, very dose dependent. That means if 500 milligrams of metformin is going to give you a HbA1c reduction of 0.5%, 2 grams of metformin is going to give you a reduction of 2%. So that means for every increase in dose that you give, you're going to get additional benefits, which is unlike other OHAs. In other OHAs like sulfonylureas, if you use 4 milligrams of glimepiride, you almost get 80% of your benefit. By increasing it to double the dose to 8 milligrams, you only get an additional 10-15% benefit. But with metformin, the benefits are there with every additional dosing that you use, up to a maximum of 2 grams. And that is the reason why when you use metformin, please use the maximum tolerated dose or go up to 2 grams in all patients. So there should be no patient who is undertreated with metformin. And again, this is not just with psychiatrists. A lot of physicians, they undertreat with metformin. They use only 500 PD, which is not very useful when we know that it is going to help you with weight. It is going to help increasing it to 2 grams a day, that is 2000 milligrams twice a day, is is going to give you double the benefit of 1 gram a day. So there are 3 different protocols I've given here. Metformin has GI side effects, and that is the primary reason why we always start with the smallest dose, which is 500 milligram once a day, and then slowly over a period of 5 weeks titrate up to the full dose. There is different titration techniques given for patients with psychiatric illnesses who are unwilling to take twice a day dose. You can even use extended release metformin and go up to 2000 milligrams just once a day after dinner. And that protocol is also given at the bottom. So any of these protocols you have to use, but the take-home message here is go up to 2 grams if possible, or at least use the maximum dose that the patient can tolerate. With this, our guidelines are now become more complicated. First line is very simple, lifestyle and metformin for everyone. The second choice of drug becomes complicated. In the current ADA EASD guideline, the question that we have for deciding what the second drug is, we ask ourselves, or we look at the patient and see whether does he have chronic kidney disease? Does he have heart failure? Does he have atherosclerotic cardiovascular disease, which includes strokes and myocardial infarctions and peripheral vascular disease? If he has any of these, then our choice of drug, if he has atherosclerotic cardiovascular disease, is a drug called GLP-1 receptor agonist. Again, we'll discuss why this may not be an option for psychiatric illness, because these are injectable drugs and these are fairly expensive injectable drugs. Or the other drug of choice for patients with atherosclerotic cardiovascular disease is an SGLT2 inhibitor. If it is heart failure or chronic kidney disease that predominates, we use primarily SGLT2 inhibitors. But if we cannot use an SGLT2 inhibitors, we might go on to a GLP-1 agonist. So this is what the Western guidelines is. You have to remember may not be easily accessible to all our patients. So we have other guidelines. Suppose they do not have any atherosclerotic heart disease, no heart failure, no CKD, then you have to decide whether the compelling need for this patient is to reduce weight or the compelling need is to minimize hypoglycemia. I think both of these are important for patients with severe mental illness, because they may not be able to recognize hypoglycemia and adequately treat it. So we have a compelling need to minimize hypoglycemia. We also have a compelling need to minimize weight gain, because most of these patients on antipsychotics are going to gain weight. And so you can see the choices that we have are now limited. DPP-4, GLP-1 receptor agonists, SGLT2, TZDs are drugs that do not cause hypoglycemia, and GLP-1 receptor agonists and SGLT2 inhibitors are drugs that promote weight loss. So we have these options. But again, finally, in India, I think we also are limited by cost. And if cost is a major issue, we may not be able to use some of these drugs. And the cheaper options that we have are, again, sulfonylurea. We can see sulfonylurea never came anywhere in any of the guidelines. But only reason it is there in the guideline is when cost is a major issue. Sulfonylureas are cheap options, and thiazolidinediones are also fairly inexpensive. And again, after we use a second drug, we then go on to use a third drug if we are not able to get our HbA1c under control. And generally, all guidelines say do not use a fourth drug because it's not going to have added benefit. If your second drug is not giving you the benefit, use a third drug. Third drug is not giving you the benefit, go on to injectable therapies. And in our case, it's primarily insulin therapy. So how do you choose which drug? Now, this guideline you may have understood, may not have understood, but how do you choose which drug to use post-metformin? And the options that are available nowadays are huge. We have at least 4 different kinds of sulfonylureas: glipizide, glibenclamide, glimepiride, and gliclazide. We have about 7 different types of DPP-4 inhibitors, starting from sitagliptin to vildagliptin, alogliptin, linagliptin. We have only one thiazolidinedione currently, which is pioglitazone. We have at least 3 different kinds of SGLT2 inhibitors. They are called glifosins: canagliflozin, dapagliflozin, and empagliflozin. We have at least 3 different GLP-1 receptor agonists available in our country right now, including dulaglutide, liraglutide, and exenatide. Even lixisenatide is available. We have obviously all different kinds of insulins available. Almost all insulins that are available in the world are available in India as well. So we have a whole choice of agents available to us. How do we choose? And I think this is where the guidelines are very vague. There's no optimal second drug. The first drug is all clear that it is always metformin. The second drug could be any one of them. And what I talk about when I talk to medical students is use what we call the ABCDE approach. Now, H stands for age, B stands for body weight, which is of primary importance in patients who are getting antipsychotic. C stands for complications that might interfere with your choice of drugs. D stands for duration of diabetes, and E, the most important, how much expense the patient is able to bear. Now, if you look at age age, generally older people may not be able to withstand some of the side effects of many of the common drugs. So the safest drug to use in older patients are DPP-4 inhibitors. They have almost no side effects, very, very limited side effects, and they don't cause any hypoglycemia. Sulfonylurea is also reasonably safe, but you have to remember sulfonylurea can cause hypoglycemia in older patients. Insulin is fairly safe in older patients, but again, with the risk of hypoglycemia. What is probably not useful for older patients are GLP-1 agonists and pioglitazone, primarily because they cause a lot of fluid retention, and older women, they can interfere with osteoporosis and cause further bone loss. And SGLT2 inhibitors, because they work on the kidney, they can cause postural hypotension. And that is the reason why over the age of 75, we generally avoid SGLT2 inhibitors. So age puts DPP-4 in an older patients, anyone more than 70, DPP-4, sulfonylurea, and insulin will be our first choice of drug. Now, for patients with psychiatric illnesses, I think, especially those who are on antipsychotics, the body weight becomes a major issue because many of these drugs will cause obesity, will cause gain in weight. So if we have to focus on body weight, I think the drugs that are dramatically reduce body weight are the GLP-1 receptor agonists, but unfortunately, they are injectable. There is one oral drug which has been approved in India, but not yet available because they are still working out what price the oral semaglutide will going to be for use in India. But my guess is it will be out of pockets or will not be accessible to most of our patients. GLP-1 receptor agonists are extremely good at reducing body weight, but are expensive and are currently available only as injectables. The SGLT2 inhibitors are also good at losing weight. We said that they excrete glucose in the urine. By excreting glucose in the urine, you lose a certain amount of calories, maybe as high as 300, 400 calories every day. That leads to weight reduction. And again, to start with, these were expensive medications, about 1,500 rupees a month, but dapagliflozin currently in the last 6 months has lost its patent. So a lot of generic versions of dapagliflozin are currently available in the country, and that makes it easier to be able to use these agents in patients who need to lose weight. On the other side, both sulfonylurea, pioglitazone, and all insulins are going to increase weight. So these are drugs which are going to lead to weight gain. Pioglitazone in particular, insulins, and sulfonylureas as well are going to lead to further increases in weight. The DPP-4 inhibitors are what we call weight neutral. They do not increase or decrease in weight, so they can be used in patients who are gaining weight as well. Now, complications, the primary complications that will reduce or inhibit or make us use less drugs are heart failure, coronary artery disease, cerebrovascular disease, chronic kidney disease, liver disease, and peripheral arterial disease. So I think when you have heart failure that predominates a drug, metformin is still a good drug unless it is stage 4 heart failure. SGLT2 inhibitors are extremely good unless there is a coexisting chronic kidney disease, which is the eGFR is less than 30. Up to that, we can use SGLT2 inhibitors, and they're very useful in reducing hospitalizations for heart failure. For heart disease, we already discussed heart and cerebrovascular disease, which is atherosclerotic cardiovascular disease, GLP-1 receptor agonist, metformin, and SGLT2 inhibitors are very useful. With peripheral arterial disease, there is a warning that we should not use SGLT2 inhibitors, primarily because there's an increased risk of amputations in them. So complications will reduce the choices that we have in terms of second drugs that we can use after metformin. Duration of diabetes really does not have so much of impact, but why I put that there as D is if you have long-standing diabetes, sulfonylureas are less likely to work because sulfonylureas work by improving insulin secretion from the beta cells, and if already the beta cells are exhausted, they are unlikely to work. So duration of diabetes, if you have longer duration of diabetes, sulfonylureas are not going to work, but all other drugs will work even with recent diabetes and long-standing diabetes as well. And finally, expenses, just to highlight that a monthly prescription of glipizide would probably cost about 2,200 rupees a month, while a monthly prescription of liraglutide would minimum cost about 8,000 a month. This is with discounts and free pens and everything that the company provides. But if they're buying it directly from the market, it probably costs them 12,000 rupees a month. So there is a huge range of expenses that are available. So if your patients are unable to afford drugs, I think sulfonylureas, metformin, there are 2 generic DPP-4 currently available. Those are teneligliptin and vildagliptin, which have lost their patent and are available as generic forms. So these are useful to use in patients who cannot afford. Pioglitazone is an extremely cheap drug, probably will cost about 150 rupees a month. And dapagliflozin are currently now available as off patent and as generic preparation between 7 to 8 rupees a tablet, which will work around about 300 rupees a month. These are options that we have when patients cannot afford medications. Now, just to highlight, because sulfonylurea is very low down in our list of drugs, but because of their cost and the fact that they are available cheaply and widely in India, they are very commonly used. To remember that all sulfonylureas work the same. It does not matter which one you choose. The newer generation sulfonylurea, glimepiride and gliclazide, they have less cardiovascular side effects. But regardless of whichever sulfonylurea you choose, you have to remember the equivalent dosing. The starting dose for glimepiride is 1 milligram, and the maximum dose for sulfonylurea is usually 8 times the starting dose. That means if you started 1 milligram of glimepiride, the maximum you use is 8 milligrams. If you started 2.5 milligrams of glibenclamide, the maximum you use is 20 milligrams. The maximum for all sulfonylurea is 8 times their starting dose. And when we shift from one sulfonylurea to other, you have to remember the equivalent doses. That because I've seen many patients who are, let's say, taking 4 milligrams of glimepiride, then go on to only 80 milligrams of gliclazide. So that is not going to work because the equivalently, it is much, much lower doses. So when we use or shift from one sulfonylurea to other, we need to remember the equivalent dosing. With this,
just wanted to remind you that you have just 2 minutes more.
All right. So I'll not talk about insulin. I'll talk finally about lipid disorders, where I will not review physiology. Just to tell you, because this was also finally told to me to discuss about lipid disorders, whom to use lipid drugs with severe mental illness. So I think first point here is anybody who has atherosclerotic cardiovascular disease, we have to use statins regardless of what their LDL cholesterol is. In this situation, we use high-intensity statins in anybody who has atherosclerotic cardiovascular disease. In patients who have LDL cholesterol above 190 milligrams per deciliter, we would use statins for everyone. And we would use what we call a high-intensity statin. I'll discuss that later. In patients with diabetes, regardless of whether they have whatever their LDL cholesterol level is, we will use what we call a moderate intensity statins for everyone. So I think these 3 things are clear. Anybody who has atherosclerotic cardiovascular disease, we use a high-intensity statin. Anybody with LDL more than 190, we use a high-intensity statin. Anybody with diabetes, we use a moderate intensity statin. So getting this out of the way, what do we do for others? So this is slightly complicated because there is no one fixed threshold for statin use among the others who are non-diabetic, who do not have heart disease and whose LDL cholesterol is less than 190. We use for someone who has 160. Do we use for someone who has 170? There is no guideline on that. So what the guidelines say is you have to calculate what the 10-year risk of atherosclerotic cardiovascular disease is. And if your 10-year risk of atherosclerotic cardiovascular disease is more than 7.5, use a moderate intensity statin. And just to highlight that if you're using a calculator, one of the calculator that we use comes from the Framingham Heart Study. And this is a calculator that is freely available online. This is from Up to Date, and Up to Date is a paid subscription, but this calculator is available free on up to date. Now, the same patient that I had, which I did not use a statin because the mother didn't ever show me a lipid profile. But if I had put his age, I had put that he has normal blood pressure, absolutely normal cholesterol, not a cigarette smoker, not on blood pressure medication. But if I had put that he had presence of diabetes, automatically his results would have come to 9.4. That is, his 10-year risk of having a cardiovascular event is 9.4%. And I just told you that if it is more than 7.5%, you need to put them on a moderate intensity statin. So I think there is no shortcut here. You have to use a risk calculator if your patient does not fall into the three previous groups. That means if the patient has not got an LDL of more than 190, patient does not have diabetes, and patient does not have established cardiovascular disease, then you have to use a risk calculator, and the information that you put is age, systolic blood pressure medication, total cholesterol, HDL cholesterol, and smoking, and the presence of diabetes, and you get the results immediately. And using that, if the results show that the 10-year risk is more than 7.5, you need to use a moderate intensity statin. What exactly is moderate intensity statin? It's any of these statins can be used, but commonly we use atorvastatin and rosuvastatin. Starting dose for atorvastatin is 10 milligrams to 20 milligrams. For rosuvastatin, it's 5 to 10. And rarely we use pitavastatin only among those who have statin intolerance because of muscle cramps and pains. Sometimes they're not able to use the standard statins. And then in these patients, we use pitavastatin. High intensity statins is only atorvastatin and rosuvastatin, but at double the dose. The starting dose for atorvastatin is 40 to 80 milligrams with high intensity and 20 to 40 milligrams of rosuvastatin. So do you have any role for the other lipid agents that we have, the fibrates, the ezetimibe? Again, remember that these are only used if the full dose of statin or statin intolerance is still not able to bring up our HDL or LDL cholesterol to goals. Then only we use. For I think most of patients with severe mental illness, the drug of choice will be statin, and depending on where they are, whether they have diabetes, it'll be either moderate intensity or high intensity statin. So I'll stop here, and my take-home message will be: please screen all patients for metabolic disorders, both for diabetes and lipid disorders, at the time of diagnosis, at the time of starting a new drug, 2 months into starting a new drug, and thereafter at least once a year. Metformin will remain the first drug of choice. Do not undertreat with metformin. Please try and put all your patients with diabetes and severe mental health issues to at least 2 grams of metformin. And if they cannot tolerate 2 grams, then use at least the maximum tolerated dose of metformin. After metformin, there is a whole choice of drugs. And in severe mental illness, if the patients can afford, I think the drug of choice will be SGLT2 inhibitors because they are easy to administer and they are the only drugs, oral drugs, which will help you in reducing body weight. But sulfonylurea, pioglitazone in younger patients who cannot afford other second-line options. We have, and based on body weight, I said GLP-1 analogs, but are expensive and injectable, but DPP-4, SGLT2 inhibitors remain the drug of choice. Sulfonylurea, very low down in the list of drugs that we use as a second drug, but because of cost, becomes a very important drug that we use in the management of type 2 diabetes. Finally, for lipid disorders, the drug of choice is statins. And patients should be on high-intensity statins if they have LDL cholesterol more than 190 or if they already have established cardiovascular disease. They should be on moderate-intensity statins if they have type 2 diabetes, or you use a calculator and you find that their 10-year risk of developing cardiovascular disease is more than 7.5%. So I think I'll stop here, and I'm sure if there are questions, there'll be more, but please follow me on Twitter if you are on Twitter. Thank you.
Thank you, Dr. Jubin. I think you've given an excellent exposition and simple to understand about management of diabetes and a little bit about dyslipidemia. in severe mental disorders. I think I'll just say something from personal experience with patients with severe mental disorders. Unfortunately, many of our newer generation antipsychotics, they do produce weight gains. Not all, but most of them. And it's a real problem. I invariably use, where weight gain is a problem, the patient is not diabetic, I use metformin for reducing weight from doses 1000 milligrams sustained release to 2000 milligrams. Most of the patients, they tolerate 1000 milligrams. Some patients, they do tolerate 2000 milligrams. And invariably, they are very satisfied with their weight reductions. It's one thing to ask patients to improve lifestyle. It's another thing to put it into practice. I think even the normal people, I think they're not motivated sufficiently to take lifestyle measures, in right earnest. But it's well nigh impossible to, I think, persuade patients with psychiatric illness to modify their lifestyles. So I think metformin remains one thing. And any time during treatment, if a patient develops diabetes, I ask the patient to go to an endocrinologist and stick to him. I catch hold of one endocrinologist for probably whole life, because he will be the one who will be following up patient, will be knowing about, how that patient is responding to different drugs and what complications probably are arising and how to manage them. So I usually ask them, unless that diabetologist or endocrinologist ask that patient to leave him, stick to one endocrinologist. That's all I think I do in practice, and I think that serves my purpose. I think most of psychiatrists' purpose would be served, I think, if they follow these simple guidelines.
Thank you, sir. It was a nice presentation. In fact, very appropriately tell the use of antistatin and also the metformin, what sir also mentioned. But one thing I just want to add, if you give metformin 2 milligram like this dose, we have to add some B complex with that. Otherwise, if you continuously use metformin for 2 years, 2 gram, then definitely there is a chance of symptoms like dementia will appear. So B complex should be added to this, B12 specifically.
Yes, so I agree with that.
Thank you, sir.
B12 should be added.
Thank you, sir. Thank you, Dr. Jubin, for the nice, excellent presentation. A very useful, relevant topic for all mental health professional and psychiatrists, because we all are using nowadays second generation antipsychotics, and this dyslipidemia and diabetes and weight gain is a very common problem. So some questions are there. So I think there are many students, they are keen to ask many questions related to your topics. So should I start asking the questions? So what is the dose range use of metformin for weight management?
In weight management, we can go up to 3 grams a day. For diabetes, the efficacy ends at 2 grams. But for weight reduction and appetite reduction, we can go up to 3 grams if it is tolerated.
Thank you, sir. Dr. Sabha Yunis, does the management of diabetes vary in patients with schizophrenia and bipolar disorder, and which of these two is more challenging?
So I think from my literature review, the treatment is not different. It is the same as we would treat any other patient without schizophrenia or without bipolar disorder. No difference at all.
Thank you, sir. Dr. Human, sir, how frequently should pregnant females with severe mental disorder screened?
How frequently? I think
pregnant female with severe mental disorder should be screened for this dyslipidemia and metabolic syndrome.
Pregnant women.
Yeah.
Pregnant women should ideally be screened for lipid disorders before they get pregnant. Women in reproductive age groups should be screened for diabetes and lipids before they get pregnant. In pregnancy, screening for lipid disorders is of no use because we cannot use statins. We cannot use any of the drugs that we currently use in pregnancy. But screening for diabetes should be at the time you see them first time in pregnancy. Subsequently, again, once more within 20 and 24 weeks, we do screen them again with an oral glucose tolerance test. That is, I think, almost mandatory by all obstetricians. Nobody would miss screening for gestational diabetes. But because they are severe mental illness, I think we should do screening even in the first trimester once and once again in the third trimester.
Dr. Gurvinder Pal Singh, any recent development in alternative to insulin injection, like any insulin pump, etc., as SMI patient has difficulty in injection adherence?
Yeah, insulin pumps, I am not too sure how useful or how patients with severe mental illness are going to use it. Even normal patients find it very difficult to use this. You need to have a lot of skills and technology savvy to be able to use insulin pumps. So I don't know whether severe mental illness will be a area where we can use insulin pumps. Currently, we do not have any other ways other than injecting insulin. Oral insulins, we have been trying, we have done many trials, but unfortunately, we still do not have a reasonable oral insulin. We do have inhaled insulin, but the amount of insulin that they have to inhale is huge. So that is the reason why it is not clinically successful.
I would be happy that if this interaction continues, but because of time constraints, can we take the last question, please?
Yeah. Dr. Alia, how to manage dyslipidemia in a patient of MDD, major depressive disorder? Can statin be used given the fact that statin can lead to mood disturbance?
Yes, so I clearly said what are the indications for statins, but in those instances where there are indications for statins, the benefits of statins are much, much beyond the side effects. So statins can cause diabetes also. Despite that, statins are prescribed to every diabetic patient because they are going to prevent cardiovascular disease, and the benefits are far beyond their risks. So I would think that statins have proved themselves that they do have their side effects and risks, but their benefits are far beyond what their risks are.
Thank you, Dr. Jubin. Because of this time restraining, well, there are a lot of questions. I think 10 to 12 questions are still pending. We may be discussing some other time or some other way. So I think we have to end this session because of the time limit. Thank you very much, Dr. Jubin, again for the excellent, nice presentation, a very useful presentation.
Thank you, sir. Thank you.
I would like to thank Dr. Zubin for the presentation, and I would like to thank the organizers to invite him, because as soon as students saw him there, they started posting questions. So yeah, thank you for giving this opportunity.
Thank you very much, madam. Thank you, Dr. Vedpal Mehla, sir. Thank you, Dr.
Thank you very much. Take care. Yeah.
And most importantly, thank you, speaker, sir, Dr. Jubin Jacob from CMC Ludhiana. It was very interactive and very interesting for psychiatrists listening from the endocrinologists. Thank you. We'll see you again, hopefully very soon. We conclude this session, and Dr. Tushar would SMS me the best question so that we announce it later. Then we have the felicitation ceremony, and we have only one physically present, that is Dr. Junaid Nabi, who was the moderator for the session. Can he come forward, and Dr. Nimesh Desai, sir, would felicitate him. Thank you very much, everyone. Thank you, speaker. Thank you, chairpersons. We move on to the next session. That is obviously the last, but the most important, I would say, as far as psychiatry and metabolic syndromes is concerned. And panel discussion is being actually delivered by the eminent and senior most psychiatrists of India. And the topic and title of the panel is Should Psychiatrists Treat Metabolic Disorders Themselves? So we are at crossroads at times that whether we should go ahead and treat metabolic syndromes ourselves in our patients who are suffering from psychiatric illnesses. So myself and Dr. Sandeep Goyal, who is President IPS North Zone and organizing chair of this program. And we have the elite panel of panelists that includes our own president, Gautam Saha, Vice President, President-elect, Dr. N.N. Raju. Then we have Professor Rakesh Chadda, sir, who is Professor and Head at All Indian Institute of Medical Sciences, Professor Nimesh Desai, sir, who is Director in Institute of Human Behavior and Allied Sciences, New Delhi, and last but not the least, Professor Dr. Vinay Kumar, who is the immediate past Secretary of IPS. He practices in Patna. May I call upon every one of them to the dais and take their chairs. Dr. Gautam Saha would be joining us.
Thank you. I am here.
Yeah, thank you very much, sir. He is the President, Indian Psychiatric Society, President-elect IIGMH, Vice President, SARC Psychiatric Federation, and Director, Clinic Brain Neuropsychiatry Institute Center, which is located in Barasat, Kolkata. Thank you, sir, for joining us.
It is my proud privilege to introduce Dr. N. Raju, sir. He is President-elect of Indian Psychiatric Society. He held many posts. He was Professor and Head and Vice Dean of Andhra Medical College, and he was Medical Superintendent of Government Hospital for Mental Care, Visakhapatnam. He was Honorary Editor, Secretary, and President of IPS Andhra Pradesh Branch, and Honorary General Secretary of IPS South Zone. He hosted IPS National Midterm CME 2017 as Organizing Chairperson. He has authored few papers and chapters in textbooks, including latest IPS textbook of undergraduate psychiatry and editor of monogram on OCD. Currently, he is Professor and HOD of Psychiatry at GVP Medical College, Visakhapatnam. We welcome you, sir.
Thank you very much, sir. We have another stalwart of psychiatry, Professor Rakesh Chadha, sir, who is Professor and Head Department of Psychiatry and Chief National Drug Treatment Center on the Institute of Medical Sciences. He is Fellow Royal College of Psychiatrists of UK, International Distinguished Fellow of American Psychiatric Association, Honorary Fellow and General Secretary of World Association of Social Psychiatry. Currently, he is holding this prestigious post. And he is Fellow of NAMS India, Member Editorial Board of British Journal of Psychiatry, recipient of 15 national awards in psychiatry and more than 250 publications to his credit, including 8 books and monographs. Most importantly, sir, you have spared time to come over, although you have a big conference coming on 16th, 17th, and 18th of World Association of Social Psychiatry. I wish and I invite everybody would join that event.
Next, I will introduce Dr. Vinay Kumar. He is consultant psychiatrist. He is Secretary, Suicidology Specialty Section, WASP, Coordinator Publication Committee, Indian Psychiatric Society, immediate past Honorary General Secretary, past Honorary Treasurer, and Chairperson, Publication Committee, IPS. He is Editor, Co-Editor of the Interfaces of Psychiatry book, IPS Textbook of Undergraduate Psychiatry, Social Psychiatry, Principles and Clinical Perspectives, Spectrums of Psychiatry, Indian Medical Association Ramchandra and Murthy Award he received in 2017. He has written many poem books, 4 books of poetry and of 2 books of prose, including an awarded and bestseller book on mental health. We welcome you, sir.
Thank you very much. I think Professor Nimesh Desai said to me, and many of us doesn't need introduction, but customary we have to introduce him. He is Director at Institute of Human Behavior and Allied Sciences. He has been at IBHAS for more than 22 years and still going on. He has been Medical Superintendent and Director since 2010. He has nearly 100 research papers and many research monographs, and has 5 national awards for his original research. He works actively with NGOs and in community-based outreach programs, and you would see him always active on TV and radio. He is also with the committees and advisory panels of national agencies like NHRC, NDMA, and CW, ICMR, and others. He has worked with these agencies for the mental health aspects of the pandemic. So he is a perfect advocate of mental health, particularly once it comes to staying in national capital, that is New Delhi. Thank you very much, sir, for joining us.
start with the panel discussion. First question is to Dr. Gautam Saha. What role can psychiatrists play in identifying the metabolic syndrome?
Dr. Gautam, are you there? Dr. Gautam Saha, are you there? Is there? We can move to the next question till Gautam Saha joins. Next slide. Next slide, Arvind.
Hello.
Yeah, please go ahead.
Question is, what role can psychiatrists play in identifying the metabolic syndrome? Are you able to hear me, sir?
Next.
Hello. Can you hear me?
Yes, sir.
Actually, network problem. What the question is, the role of psychiatrists play
in identifying the metabolic syndrome. Yes, sir.
We have a great role because all of us, we know that the psychiatric medications, especially antipsychotics, have an immense role in creating the metabolic syndrome. In these cases, so we have to be cautious. First of all, I want to mean that we should have some mindset that this drug can cause metabolic syndrome, which is more important that if we have got that mindset, so we have that knowledge also which drug is more susceptible to cause, like olanzapine, atypical antipsychotic like risperidone. All these drugs are creating these problems. So we have to know, and what to do is we should start from the baseline investigations. Initially, when we see the patient, we are prescribing this antipsychotic medication or other psychiatric medication which may cause metabolic syndrome. We have to do some baseline investigations like blood sugar, lipid profile. We have to check the BP. We have to measure the BMI, body mass index. That means height and weight. And also, we have to take the history of whether there's history of smoking is there or not. Because all these are very much important. And if you ask the monitoring system, at the outset, you should check all these parameters. And the initial visit, we can see all these parameter, and body weight should be checked by every month in the first 3 months, and then every quarterly, I mean, in every 3 months. And other parameters, what we can do, usually after 3 months first, we used to check it once in a year. But for the better, if any suspect that metabolic syndrome can develop, we can do it more frequently than what guidelines suggest us. That is my personal experience. Thank you so much.
Thank you, sir, for enumerating the roles of psychiatrists in identifying the metabolic syndrome.
The next question goes to Professor Chadha, sir. While choosing psychotropics, what should the psychiatrist do to prevent development of metabolic syndrome? From your vast experience, sir, while choosing a psychotropic, what should be the psychiatrist do to prevent development of metabolic syndrome?
Good morning, and thank you, Dr. Majid. There is likely to be overlap in the responses which we would be giving. And in the last one day, means yesterday and today, we have had a number of new knowledge emerging from different presentations. When we talk about our patients, be it of any illness, whether it's depression or psychosis or even OCD or anxiety disorders, our patients, often the medications have to continue for long time.
some of the medications, especially like in antidepressants, fluoxetine and sertraline, they have got lesser weight gaining potential. Now, amongst antipsychotics, most of the antipsychotics which have proven efficacy, proven and fast efficacy, I would say, like we have aripiprazole, but with aripiprazole, it may be safe for metabolic profile, but often the efficacy is not that much, that because if the patient is an acutely agitated patient, you can't control that with a medication like aripiprazole. So you have to go for risperidone or maybe olanzapine or quetiapine or clozapine. So we have to go for, then we have to see the patient, what is the profile of the patient. Like if patient is a very thin build or has already lost weight because of psychosis, and so in that case, you may go for olanzapine because olanzapine as such would be helpful in controlling agitation, improving sleep, improving appetite. I remember very well seeing at least, I think, 3 patients around 10 or 12 years ago. One was, and 2 of them were very tall 6-footers and came with a body weight of just 34 or 32 or 35 kg. Now, in such a patient profile, because who has lost weight because of the long-standing psychosis, you can go for some medication with a potential for weight gain, because weight gain is required in such patients. But so again, this would vary with the patient profile. Now, even for OCD, because there also the medications have to be continued for a long time, so you need to go for medication as per because, and sometimes you may have to go for augmentation with risperidone or some other medication or clomipramine as an augmenting agent, which all have got potential for weight gain. One thing in which we psychiatrists are notorious, we often don't examine the patient physically. In my earlier days, I had a habit of at least examining the pulse of the patient. But as I have grown senior, that habit has gone away. And sometimes some mishappening takes place with you. And like patient, all of us face that kind of problem. The patient has physically assaulted you and you start maintaining a distance of 4 or 5 feet. And with the COVID, that distance has gone to 6 or 7 feet. So, but the word of caution is, and the word of advice is, like yesterday also I said, we should keep, because measuring tape was never a part of your armamentarium. Measuring tape, blood pressure, and BP, and the weighing machine. Keep these in your clinic, just besides your table, because we don't have the examination table, we have table chair and office table and 2 or 3 chairs in our clinics or wherever we are working. So keep a measuring tape and BP apparatus definitely, because these days these are very handy. Not older times, the sphygmomanometer, that was not easy to handle because that would occupy a lot of space in your briefcase or your, and so these things. And yesterday also, as Dr. Sandeep Rohrer had also mentioned, sensitized that the waist circumference is the most important parameter, and which is often missed. Often we are not taking waist circumference while we are examining our patients. And don't rely on nursing sister or your helping hand for these things. You can do these things yourself. And another thing which I mentioned yesterday also, on the OPD card itself, when you're writing the prescription, they just write WC, weight, and so that makes that sensitizes the patient also, because these things are important. And so all these things, they will help in reducing the risk of patient gaining weight. So these are some basic steps which we can take while treating our patients, whether it's of chronic depression, whether it's a bipolar disorder or OCD or schizophrenia, in which the treatment needs to be continued for a long time. Also write about the daily physical exercise and say walk for half an hour, walk for 40 minutes. So that kind of schedule needs to be built up in the daily routine of the patient. So these basic things definitely will help in reducing the risk of metabolic syndrome. Thank you.
Thank you, sir, very much. On a lighter note, I had one patient when earlier before COVID, I used to check his waist circumference. He was obese, protruded belly, but he was bipolar as well in mania. He told me that I thought you are stitching a band for me. You only took the waist circumference, not the rest of the measurements. On a lighter note, thank you very much, sir, for your answer.
My question is for Raju sir. What should the psychiatrist tell about the metabolic side effect of psychotropics to their patients and their caregivers?
Thank you, Dr. Sandeep, and thank you and your team for organizing such a nice panel discussion, because I'm sure many experts have spoken about metabolic syndrome for the last 2 days, and this is an occasion where perhaps we will be talking things which no textbook tells you, and nowhere do you read, because this is just this is the question which Dr. Sandeep has already put. What would we tell the persons with mental illness and the caregivers? I think the most important thing we should understand is that whenever we deal with any person who has come to us, doesn't matter about metabolic syndrome, or maybe Dr. Ravi would be interested in sleep disturbances, but we need to tell them what all we are doing, why we are doing it. I think they have every right to know what we are doing. Tell us why we are doing it. Knowingly that suppose an X drug, so let us say olanzapine causes metabolic syndrome, still why do we give it? It is going to harm me. Already our patients are, I think more than the patient, the relatives are more paranoid about the side effects of the drug. They all say they are habit forming, they are damaging your body, you unnecessarily pump us with drugs. The questions which no other physician gets. That is the, I think, negative side where we had to face. So obviously the only way for us to tell them is explain it. So not only just that, telling them that it causes metabolic syndromes or what metabolic syndrome, more than that, probably describing them. I think spending some more time with them that what this drug is, why it causes that, and why I'm giving this. What are the, like as Dr. Jack already, the endocrinologist so nicely described, the advantages outweigh the disadvantages that extra carries. So explain it to the patients. Sometimes it may not be easy to explain it to the patients in our scenario. Maybe we can talk privately with their caregivers, because some of the patients may not have the insight, and already they include the treating psychiatrists in their paranoid community, that they are hand in glove in damaging them or in whatever they want to do it. So maybe you should take care of that. So take care of everything that needs to be explained. Explain them the physiology, explain them about the pharmacological, likely in the terms which are understandable to a common man. Don't talk the way in which our speakers spoke to you, because you know everything. So they talk in terms which they understand things. Remember that all drugs have side effects. Tell them that why the side effects occur. So there is no drug which does not have an adverse effect under the sky, including the painkillers or whatever we give it. So tell them that this is the benefit. So if you explain, I think this is all what we need to explain them. Tell them what you're going to prevent those side effects, what care you're going to take. So give them confidence that you're at their call. If anything happens, I'm there to take care of those side effects. So this, I think if you explain why majority, almost all of them accept your words. Majority will come back and say they're drowsy, they're putting more weight and all. So please tell them, if you have alternatives, do also explain what alternatives you have, and also tell them the problems with those alternatives. Even though I have an alternative which does not cause metabolic syndrome, still I have chosen this drug because this gives you far more advantage. This gives you far more relief. This brings you back to normal far more better way than that drug. Whatever you feel, whatever the science is. Thank you so much for giving this opportunity.
Thank you, sir, for a wonderful answer and explaining the need to tell the patient and family in simpler words and telling why I have chosen this drug. Thank you.
Question for Professor Nimesh Desai, I suppose, yes, sir. Many a times we psychiatrists are caught in catch-22 situations, particularly once your patient has responded to a drug, especially those which cause metabolic syndromes or are notorious for actually leading to it, like antipsychotics, predominantly clozapine, then antidepressants like metazapine. But generally speaking, most of the psychotropics do cause metabolic syndromes. But once your patient has responded, you are in dilemma whether to continue or discontinue. Sir, what's your take on that?
Thanks, Majid. Thanks to you, both the Sandeeps and that Not Zone Organizing Committee and the Pharma group. The thing is, your panel session is titled beautifully. And if you all don't mind, I'll begin from there before you come to the specific question. Should psychiatrists manage metabolic syndrome? To me, it has seemed from the time you have shared the title for the panel that it will so depend on at least two major factors. One, the setting in which you are working, and two, your choice and comfort. If you're working in a general hospital psychiatry unit, a top-notch institution like AIIMS Delhi or CMC or even a medical college or a district hospital, and you have an endocrinologist who is willing to collaborate, wonderful. You might continue to do that as joint management. If you happen to be in a neuropsychiatry specialty mental health institution, again, you'll have to decide whether you have an endocrinologist next door like we do at IVAS to do that. But if you happen to be, let's say, a private practice colleague who is running a nursing home of his own, or happen to be at a mental hospital or a mental health institution, does not have that collaborative potential, then surely you'll have to decide that you'll have to perhaps refer the person to another colleague or another center. Most importantly, large part of our colleagues in the Indian situation function from individual chamber practice. What do they do? That is where I think the most important issue is your choice and comfort. Your background knowledge, your choice and comfort. I would individually say that it's quite all right if in the early stages of metabolic syndrome, if you want to still manage the metabolic syndrome with the psychiatric illness by yourself. And to that extent, this two-day event has been wonderful. Not just the 200 or 300 people who have attended, but so many others who, in fact, if we pay attention to that. On the other hand, if there's an individual practitioner who would say, I prefer not to, then you might have this very difficult choice of what do you do? Like you said, it's almost a option choice. The person has responded well for his psychosis or the severe mental disorder to the drug. And yet you have the indicators of metabolic syndrome. While there is huge need for, as has been said since yesterday, beginning with Sandeep Grover so well, and everybody almost, there is a need for us to be aware of, for us to be alert to monitoring, for us to pick up, and for us to, as was said by Dr. Raju and in your question, to sensitize the people. I also think that, and I'm going to go out on a limb and say, I don't think we as psychiatrists need to get scared of metabolic syndrome. I hope I'm able to get this fine balance across, and I hope our colleagues here will agree. While there is certainly all of that need to be aware, not to miss it, monitor, in all cases that are emerging or mild, I don't see why a medically trained psychiatrist should not be able to deal with it if he or she is confident. Like Sandeep Grover said so eloquently yesterday, and that resonated so well for some of our colleagues and myself, we cannot forget that we are essentially a medically trained doctor who should be looking at holistic management. And so emerging or mild metabolic syndrome should be easily possible, as we will discuss, I'm sure, in the next few questions, by what strategies, and as has been said enough. But I will repeat one more time, it is a matter of your choice and comfort. If somebody wants to say, yeah, I don't prefer to do all this, your question about drug, I think we need to have very clear in our mind among the drugs available, the drugs which are high risk, the drugs which are moderate risk, and the drugs which are low risk. I don't think there can be any doubt that olanzapine and clozapine are the high risk amongst the second generation atypical antipsychotics. Clozapine, you might well have a person on because he has been treatment resistant, and so you might have no choice but to continue clozapine. In which case, you'll have to have all the management of metabolic syndrome that I'm sure we'll talk about even in the next few questions. I do have a bit of an issue with the rate at which many of us in different settings use olanzapine. Besides the marketing push, there is this huge thing of how it controls the symptoms. I think we forget that use of benzodiazepines for control of psychotic agitation or restlessness is the order of the day for last 20 years. And so even if you choose something else which is less metabolic syndrome inducing, I think it should be all right if initially you use benzodiazepines with that. So I really have a lot of discomfort with olanzapine as the first drug of choice among the second generation antipsychotics. Ziprasidone, lurasidone are two drugs which are known to be the least among the second generation antipsychotics. If you are comfortable as a clinician using those, do that. I must also say that I think there is the resurrection or resurgence, like it happens in fashion, from bell bottoms to skin tights to back to bell bottoms to skin tight trousers. I think there is a resurrection for typical antipsychotics to an extent. And almost all of us got carried away by the advantages of atypical antipsychotics, which is nice. But maybe in patients who are prone to, or those who already have risk factors for metabolic syndrome, maybe you need to choose typical antipsychotic rather than a second generation typical antipsychotic. So I really think that it's a matter of how you choose. Unlike NHS or many other settings, we are all not working in similar settings or with similar competencies. And so to repeat myself, you'll have to assess whether you want to do it or not and to what extent. You'll have to draw your Lakshman Rekha yourself. Yes, what would be unethical, if not almost criminal, is not to even realize, not to be aware of, and not to decide that line as to where am I going to stop my expertise, where am I going to ask for collaboration, or maybe refer to another center. That would be unethical.
Thank you very much, sir. Thank you for your comprehensive answer to the question. Thank you. Next, Arvind.
The question is for Dr. Vinay Kumar. How frequently should the psychiatrist monitor the patients for metabolic abnormalities?
Thank you very much for inviting and giving me opportunity to discuss something. Sandeep and Majid. The first, basically the title question, which was not put in the panel, in front of panelists, has been answered by Dr. Nimesh Desai beautifully. But I would like to simplify it, that there are two questions. Can we treat metabolic syndrome or should we? Can we? The answer is yes. Legally, there are no limitations, no restrictions. Should we? It raises questions, ethical questions. And ethical questions are answered usually by the person who is doing the job. So, the moment this question comes, we must think, are we capable enough? Do we know everything? So here comes the question of knowledge about the subject. Apart from that, there is a legal question. Law is permitting you to prescribe everything. But if something happens to patient, are you able to defend yourself in the court of law? Because they will examine you on the parameters of 4D, duty, dereliction, and direct damage. So they will ask, was it your duty? Number one, have you performed your duty well? Number two. Number three, they will examine, they will look for any dereliction. And number three, what you have done is directly related to what has happened to patient. And number four, the damage. So that should be kept in mind. But to conclude, I would say, in primary setup, in emergency setup, fine, we must, and that with knowledge probably we have from our MBBS training and whatever CMEs we attend. But for specialists, the way specialists act, for that, we must have a kind of training of consultative liaison psychiatry. Recently, Dr. Chadda and AIMS team has published a beautiful book on consultative liaison psychiatry, and the book is available to entire India free of cost what a generosity from the team AIMS. So we must appreciate that. And so in that condition, the issue comes of consultative liaison psychiatry training. I remember one editorial I read somewhere by Norman Sartorius in which he says that we do not have any liaison orthopedics, liaison cardiology. We do have this liaison psychiatry simply because it is universal that we psychiatrists are not oriented to look for medical comorbidities. We develop kind of tubular vision. It is right. To begin with, in the beginning, I had a kind of proper examination table in my chamber, but with the growing age, everything is gone. And now I see patient. There is a mic for patient outside. There is a mic for myself. Speaker outside, speaker inside. In COVID era, and everything is partition. There is a partition, glass partition. So we have reached to this level, but everybody has a team, and team building is important. So that is important. So consultation liaison psychiatry training is important, and team building is important to look for what we have to do, because monitoring work, which I have to answer. And yesterday it was also discussed. So there is not much to add, but for that you need a team. Many things like measuring tape and blood pressure measurement can be done by your staff in your private clinic as well. I am speaking from my experience because I do a private practice. So American Psychiatric Association and American Diabetic Association, they have simplified things in a very, for us, very simple. That baseline measurement you have to do, BMI, abdominal circumference, assessment for blood sugar, lipid profile, blood pressure. So that has to be done. And after 4 weeks, what you have to do? Only body weight. So your job is very much less. At 8 weeks, only weight measurement. At 12 weeks, weight measurement and other parameters to be checked. And every 3 months, weight measurement. Annual, try to check everything. And I remember, I think International Diabetic Federation has also added that for hyperlipidemia, you must be a little careful annually. Every year you must examine that. And every 5th year, you must look for only hyperlipidemia. So these are the parameters, and these are the indications. But from my experience, I would say what happens in psychiatric clinics. Patients are, if you ask your patient to come after 4 weeks, they will come after 4 months. They will come after 2 years. You prescribe for 15 days, they will come after 1.5 years that I was taking. So it is important to tell the patient well in advance, as Dr. Raju explained, that the drug is going to do this. So you have to be careful. Please come on this date. Please get this checked up. Consult some physician if you have some problem, like that. So patient training, patient education, attendance education, caregivers education is important because our patients are not very prompt. So I think I have completed my answer, Majid.
Thank you, sir, for a wonderful answer. With this, we move to round 2. And due to shortage of time, I request all the panelists to be brief for this round. And my first question goes to Dr. Nimesh Desai, sir. What is the role of various pharmacological agents in management of metabolic abnormalities?
I think the last talk by Jacob was very useful. So I prefer that. I think the last talk by Dr. Jumi Jacob was a great reference for that. But let me one more time elaborate 5 steps. Screening and monitoring, change polypharmacy to monotherapy, change drug as per our last discussion, lifestyle modification, 5th, metmorphin, topiramate use somewhat. But metmorphin with the dose calibration that Jumi Jacob spoke about. Gautam Saha's very good writer about vitamin B12 supplementation. But I will still repeat, I don't see there is a reason why, like Dr. Vinay Kumar and all of us are saying, why we should not be confident of doing that. We can't really be so lacking in confidence as medical professionals, being psychiatrists, to kind of keep referring and getting scared of metabolic syndrome. Having said that, like Dr. Rakesh Chadha said so well, telepsychiatry, which is becoming quite the order of the day, is going to be one issue, because I don't think defense will hold if there is a conflict. If there is a conflict, telepsychiatry में मैंने exam में नहीं किया था, test नहीं कराया था. Same. Let me say this also very briefly from what Dr. Vinay Kumar was saying. It occurred to me. Insurance, we are all very thrilled about, and hopefully sooner than later, hopefully, insurance for mental health will happen. But those of us who are familiar with the insurance-driven or health HMO-driven care in the USA must also realize and bring to our colleagues' attention that insurance companies actually ask you every question very painfully when there's a complication. And so you'll have to be very sure, either you get it in the scheme that alongside psychiatry management, I'm going to do the metabolic syndrome management. Or at least, as Dr. Vinay said, make a reference, get an opinion at least once, if not at a frequency. Because insurance companies are going to ask you very uncomfortable questions on the other end of the argument that I am saying. So it's there is also, I must say, the cliched India versus Bharat issue. I mean, teaching centers and major cities is one issue. And again, as Dr. Vinay said so well, you call the person every 2 weeks or 4 weeks, they come up every 4 to 6 months. So are you going to be responsible for that lack of monitoring? So these are the issues, both, especially to recap, telepsychiatric and insurance for mental health services are two things that we will have to really watch very carefully, especially when it comes to the so-called unexplored areas of medical management of metabolic syndrome. We'll all have to wait and see how we evolve.
Thank you, sir. Thank you very much, sir. And next question is for Dr. N. Raju, sir. Where Dr. Vinay Kumar ended about consultation liaison psychiatry. What kind of liaison must be maintained with other physicians to maintain metabolic abnormalities?
I think already most of these answers must already have come from my colleagues, and my liaising with other colleagues would be as much as their liaising with me. It's literally liaising with my physician would be as much liaising the physician does with a psychiatrist when behavioral problems come. And secondly, as all panelists said, when we treat, who treats extrapyramidal symptoms? Who treats Parkinson, pseudo-Parkinson? I think we do better than the neurologists. Why not metabolic syndromes we do better than endocrinologists? Please, I think this is a new entity. That's why we are all discussing it. In fact, I am uncomfortable with this question for the simple reason that I would treat this. I would maybe, as a colleague, I will discuss with my friend over phone if I have a problem. And referring to endocrinologist would be my last option. I continue to treat it. I am as much comfortable with treating it as, because most of the people think they just stop the drug and do. I think they do more harm by referring the case to a gynecologist or to a cardiologist or to an endocrinologist. Remember that. They're going more harm to your patient by just asking and also making some loose comments saying that these drugs have damaged you, that type of thing. So I advise my young colleagues, read about all these things, be more, I would say, within quote, more doctor, do radiophysiology, pathology, everything. Be more comfortable about what you do. You read it, nothing wrong in that. They also don't know. They know as much as you know. So please manage yourself. Have a nice friend. Have a good liaison. Nothing wrong. That also improves your practice. So have a liaison with them. Discuss with them. This is what I have. This is what I have done. If there's something, I think your nice friend will never criticize you. He would tell you that no, you can increase metformin to 2 grams or 1. I think we all have good friends. I'm sure Majid would be having more good friends than I have. So we all have good friends. They all will help you. So liaison with them as much as they do with you. And that is good, nice atmosphere we have. And I'm sure all of us can manage. Thank you so much.
Thank you very much, sir. Actually, this question was put to express the discomfort not only from Dr. N. Raju, but from the Vice President of Indian Psychiatric Society, conveying to everyone, online, offline, that we are medical doctors first, then we are psychiatrists and competent enough to deal both of them.
More you do it, more you operate. Less you withdraw, less you operate, right?
So my next question is to Dr. Gautam Saha. What kind of medical emergencies should the psychiatrist anticipate in patient with metabolic abnormalities? Sir, are you able to hear me?
Yes, I am here. I am sorry. My apology because I am right now in a medical health camp. So in the midst, it is really problem. But yes, sir, what you asked, that what kind of medical emergencies should a psychiatrist anticipate in the patient? There are two or three important medical emergencies we have faced patient with metabolic syndrome. Number one, there might be a sudden cardiac attack, sudden cerebral attack. There may be a diabetic ketoacidosis. In fact, in metabolic syndrome, there are so many psychiatric patients is associated with alcoholism, substance use disorder. In that case, withdrawal syndrome, we have to keep in our mind. So, except the withdrawal syndrome or dependent syndrome, in other conditions, we have to refer those patients to the medical specialist, consultant physician for tackle. And this is all the things I can say briefly. And the acute emergency is one thing that patient might call you at the midnight, might call you, inform you that I have a chest pain, I have a severe headache, I had a history of continuous headache with vomiting, or I have a paralysis or a hemiparesis or anything else like these symptoms. So just don't ignore all these symptoms. Always as psychiatric symptoms or as a functional symptoms, we have to very much careful. You have to examine. That is why I always say for a psychiatrist, it is to be a very good physician, or to be very more specific, you should know the very good neurology, because there are lots of time, even with the organic disease, they refer to the physicians, refer to us as a psychiatrist. So neurological investigation is equally very important. As this program is for the PGTs, I am telling you, neurology, you have to know, not even only neurology, ophthalmoscopy, also very important and integral part of the training, because I know there are lots of headache. If you don't see the blood pressure, if you don't see the ophthalmoscopy, whether there is papilledema or not, it is in fact, maybe I am harsh enough to say, it is a crime if you not see the blood pressure, don't see do the ophthalmoscope, and don't do the neurological examination. So for the younger friends, the PGTs, please take it very seriously, because neurological examination and overall medicine is very important for any psychiatrist.
Thank you, sir, for a brief and crisp answer hitting bullseye.
Next question is to Dr. Vinay Kumar. Sir, what's the impact of metabolic abnormalities on neurocognition?
Metabolic syndrome affect brain globally, mild cognitive impairment, executive functions problems, working memory problems, vascular dementia, vascular depression. So all these things are very common. I remember Dr. Grover is sitting here. He has done a beautiful multi-center study on the cognitive, neurocognitive dysfunction. I would like to share a few findings from his study. Patient with metabolic syndrome has significantly poorer performance in the cognitive domains of processing, speed, cognitive processing, and selective attention. Patients with metabolic syndrome have significantly poorer auditory and verbal memory and immediate recall memory, and higher number of abnormal components of metabolic syndrome. If they are associated with poorer function in domains of cognitive processing and selective attention. auditory and verbal memory, and executive functions. So, to save the neurocognitive functions, metabolic syndrome has to be managed, has to be treated, taken care of very promptly, carefully, and on a long-term basis. Thank you. Handing over to the moderators to save time.
Thank you very much. Please, Dr. Sandeep, go ahead.
With this, we move to the last question of the panel discussion. My question is to Dr. Chadda, sir. How research should move in the direction of understanding the association of metabolic abnormalities and various psychiatric disorders?
Thank you, Dr. Sandeep. This is a very good question. Many of us, or rather I would say most of psychiatrists in clinical practice would think that research is not their domain. When we are talking about research, every research is not done in laboratories or in big hospitals. Actual research is done in clinics. So it's a clinical research which is most important. And clinical research can be done by anyone, even person who is sitting in a private chamber or in private practice. The area where we are deficient is we are deficient in record keeping. And in fact, that is a kind of Indian tradition. Our Vedas or our ancient Indian literature or even that was never written. It was passed on orally. So that's one area where we are deficient. And if we start keeping proper records, and it's not difficult to keep because now with the advances in the information technology, simple mobile phones or laptops or computers, everything is so cheap and connectivity is so cheap. You can easily keep records of, and these are the basic records. It's not, I am not saying that we keep a records on measuring on different scales. Simple biometrics, blood pressure, or these things, and because that sensitizes you to monitor the side effects, monitor the various parameters. So that helps, and that is the kind of clinical research we can do. In fact, if I talk about myself, most of my research has been on the clinical data, and that can be done by anyone, and that helps in finding out where you are deficient, where your treatment is deficient. If you are keeping a record, you are able to judge yourself also, and this accumulated data definitely can be shared, can be published, and in different forums, and can be published. So that's the way all of us, or most of the clinicians, can go for a clinical research, and there I would strongly recommend it. And as we grow in experience, I remember, I may be shooting in time, but I thought I should share this experience. We got close up in 1995 in India. That was the first atypical antipsychotic we got here. I remember Dr. Desai, and I was also part of that symposium. We shared one local panel discussion in Delhi. And 97, we got risperidone. And I was talking to a colleague who came from Australia at the time in 98. That time we had, because close-up leads to agranulocytosis and some other major side effects, there should be a drug which does not have a fatal side effect of agranulocytosis. And olanzapine had come with that kind of promise that it's just like clozapine, which would be effective in resistant cases and won't have the side effect of agranulocytosis. But another year, and we started the moment it was introduced, within weeks or months, we started seeing the side effect of weight gain, hypercholesterolemia, and other lipid profile. Those were not being done in routine in those days. But next few years, the concept of metabolic syndrome as a result of atypical antipsychotics came. So everything, this is a part of clinical experience with which we got these noticeable side effects. So that's why I'm saying the clinical research, because if you keep a proper record, definitely you will keep on finding out, and you will keep on strengthening your practice and making it more safe clinical practice. So this is my message for this topic, that should research be, what should be the aims of research and how research can be done. And that's applicable across all medications, whether it's metabolic syndrome induced, antipsychotic induced metabolic syndrome, or any other clinical practice. Thank you.
Thank you, sir, for a wonderful answer. With this, we come to end of this panel discussion. And due to shortage of time, we are not having any question answer session in this panel discussion.
Thank you very much, Professor Rakesh Chadha, sir, Dr. Vinay Kumar, sir, Professor Desai, sir, and Dr. N. Raju, sir, our Vice President, and Dr. Gautam Paha from all the way from Kolkata, although he's busy in a medical camp. Thank you very much for joining us, and we conclude the session on time. So, yeah.
It is time to felicitate the panelists and the moderators. So I'll invite Dr. Ravi Gupta to join me to felicitate the panelists and the
You can go on one side, sir, Dr. Sandeep. You can be there. Next is Professor Nimesh Desai. Dr. Sandeep Goyal, I'll send it. Dr. Sandeep Goyal to Professor Rakesh Chadha. Dr. Sandeep Goyal to Dr. Vinay Kumar.
I'll felicitate the President and the Secretary. So first to the President, Dr. Sandeep Goyal. Yes. Finally, Ravi, you can come up.
I think we can adjust postgraduates behind us.
One of you can come. Those who are in the hall, please join.
हम आगे बैठेंगे, they will sit there. Oh. Just a minute, just wait for it. What's he said?
All of you please join. Abhinav, आप ले लो फोटो. आ जाओ.
Abrar आप उसे. Women empowerment all over. Oh. Well, what's that?
Small announcement. Those who are checking out today, please, those who are leaving today, please check out before the lunch. Yeah, now we are moving to the valedictory function. Yeah.
All good things come to an end, and so is this program. Now, I request Dr. N. Raju, sir, President-elect, to be on the dais. Dr. Sandeep Grover, Editor, IPS Norzone, and Dr. Abdul Majid, Secretary, and Organizing Secretary also, to be on the dais. And I request the delegates and faculty in the audience to give their feedback and comment.
Sir, आप बैठे, 2 मिनट बैठे. चड्ढा सर, आप बैठे. First, I think if anybody from online can speak, if there are any. Yes, sir. Chadha sir.
Yeah, I would like to congratulate IPS Norzone for organizing such a wonderful PGDP, that the postgraduate development program. The topic chosen was excellent. And in fact, I came specially for this program to get a feel of, because it has been almost 1 year, 10 months or 11 months that I attended any program. And I learned a lot, especially about organizing the hybrid program. And I'm getting more confidence of, because the coming week we are having Asia Pacific Hybrid Conference, Congress of the World Association of Social Psychiatry, which is which is a grand event, having 9 parallel sessions going on for 3 days. And I would like to give another message that all PGs can register as complimentary. I have informed Sun Pharma also to circulate this information across the country. And this is going to be a very academically very rich program. And the timings are from 2 p.m. onwards, 1:30 p.m. onwards, when you have completed your clinic, so everyone can join. And this will continue till 1:30 to 9 p.m. So the only thing is you'll have to give your details, and you have to register on the website of the Congress. And so that's another message which I wanted to give you. Thank you.
Thank you very much, sir.
Anyone from the students?
Anybody can speak. How your 1.5 day has been? Anybody? It's not always winning about the awards in the form of questions. Anybody? Okay. Said Mahvish, am I right?
Good afternoon, everybody. I am Said Mahvish. I am an outgoing PG. I'll be kind of a registrar now. So I actually learned a lot in this conference. So basically, my concept would be to, to just shift the patient to the endocrinologist for the metabolic syndrome, for treating that. But now I've learned that first I'll consider myself. I'll treat the patient myself. And if I have to, kind of make any modifications in the treatment, I would definitely consult an endocrinologist for the betterment of the patient. But I'll first start by treating myself, the patient. So that was it.
Thank you very much.
Thank you so much.
Thank you.
Anyone else from the audience?
Ajaz?
Respected dignitaries, it was very helpful session regarding the academics, and I was much honored being in front of such great dignitaries of psychiatry and stalwarts of psychiatry. Thank you very much.
Now I request Dr. N. Raju, sir, Vice President cum President-elect of IPS, for concluding the valedictory.
Thank you, Dr. Sandeep, Dr. Sandeep Goyal, Dr. Majid, and Dr. another Sandeep. Good friends. I think I made more friends now in North Zone, and I think this is a program which is blemishlessly done. No, I think everything meticulously organized and on time. That is more importantly, I think at very hard taskmaster, Dr. Majid, sitting with the mic. I think it has been a brilliant and excellent, as I think the final statement made by our postgraduate, or who has finished, I can't call her postgraduate anymore. I think she's an outgoing postgraduate, who said that now she would treat metabolic syndrome. I think that is the purpose of this entire program, and I think that has been achieved. So I think I will conclude with a nice Sanskrit sloka I remember from Natyasastra, which says something like this: Yada hasta tada drushti, yadha drushti tada mana, yada mana tada bhava, yada bhava tada rasa. That means if you want to do something, yada hasta, hasta means hands. Basically, it is from dance, so they concentrate on hands. But your drishti, your eye with vision will go. Yada drishti tada mana. The way you want to see, your mind tells you. Yada mana tada bhava. Your thoughts will go along with that. And yada bhava tada rasa. So you get emotions out of that. You be pleased with those activities. So more you want to do, more your mind will tell, and more pleasure you get out of it. And you want to do it again and again. Your positive reinforcement comes back. something like the positive enforcements which we have, we want to come back to Srinagar again and again. Thank you so much. It has been a fantastic program.
Thank you, sir. With this, we conclude the program. But before that, I thank all the faculty, chairpersons, students for attending the program for full one day and making this program a grand success. I'm really thankful to all. And I want to make an announcement. We have annual conference and tentative dates are 11th and 12th December in Chandigarh. And I invite all of us sitting here and online also. And with this, I ask Dr. Majid for the final remark.
Thank you very much, Dr. Sandeep. As you rightly said that we have 11th and 12th of December, our annual conference, and I would love that a bit down, although I'm the last in the sense that many of our postgraduates and senior residents don't come to our annual conference. A bit feeling betrayed by that. We need to actively pursue our cause of uplifting our IPS North Zone because it gives you platform to win awards, excel in academics and research. So I am absolutely hopeful and sure that in future times to come and starting from this conference that you will put your efforts into submitting award papers. It's not all about attending conferences. Submitting award papers, that is how our minds will open up to newer heights. I invite you all of you, those offline and online, to the annual conference to be held on 11th and 12th of December. And coincidentally, both Sandeep Goyal is the organizing chair. I am the organizing secretary for the conference, probably to be held in Chandigarh, and Sandeep Grover is the backbone of this triangle. So thank you very much all, and offline and online, and Dr. Sandeep to finally conclude it.
At last but not least, I want to thank the Sun Pharmaceuticals, who is the sole sponsor of this PG development program for last 21 years. To be exactly, this was the 21st PGDP program. I'm really thankful.
Recording stopped.